So with the permission of our mentors as well as all the faculties, good evening everybody to the mock test 2 debrief. And we have designed this in a way that would definitely help you in your preparation for your final practical test, which is could be in next 1 month to go from today. So this is the DNB notification, which says that the practical examination for the DRNB, which is your DNB-SS super specialty, would cover clinical case, 2 clinical case examinations of 50 marks each, ward round, viva, virtual OSCE. So this is the first batch for the DNB practical, and this exam, this mock test would also help the DM candidates for their practical, and in a way it would also help all the IDCCM, IFCCM, PDCC as well as the EDIC to the aspirants, because the format is more or less similar, and we have gathered information across the world, because I have got some the flow from my training institutions, that is the St. Michael's Hospital, and also Sanant has also brought some ideas from the his training country, which is Australia. So we have gathered the informations and we have made it very lucid and useful for you to go through, that will help you to present in a structured way in the real practical exam. So with this background, this is the flow. We would be going ahead with the long case 1 by myself. Then there will be ECG by Dr. Mona Lisa. Then ventilator and other graphics by Dr. Santanu. Data interpretation would be taken by Dr. Santanu, as Dr. Kishore is having some family issue. Radiology will be by Dr. Vishwabikas. The communication station by Dr. Swarna Deepak as well as one of the candidate. And then critical appraisal, if we would have the time, definitely Dr. Niranjan Panigrahi. So welcome all of you, and let's start today's discussion on the long case. So before the long case discussion, as it is not a the theory class, I would be starting with how the initial stem would be given to you. So in the real exam, you will be given a clinical short history with an opening question. And the opening question would be assess this patient and identify the current clinical issues. How will you progress this patient? So this would be the questions. After that, the examination will start. Now, our advice to all of you, the trainees, that before you prepare and commence examining the patient in the real practical exam, try to provide an approach. So it has to be with an approach, a structured approach, that how to evaluate the patient which is in front of you on that day of your exam in mind before jumping into examining the patient. So just have a structured in your mind. Maybe it will take 2 to 3 minutes time or maximum 4 to 5 minutes time. But after that, your job would be very easy. Like how and what are the things you would be checking and keeping in mind, so that at least in the the practical exam, when the examiner would ask you, it would be just a cakewalk for you. So what you expect to see in the bedside, just keep all those things in your mind. This is a structured format which we thought this would be helpful to you. First one, which is important to you, is the patient. Patient is lying on the bed, whether he is intubated or tracheostomized, ventilated, what are the sedatives and paralytic agents the patient is on, is there any vasopressor going on for that patient, what is the dose of the vasopressors. With the background, you can guess whether the patient is critically sick or the patient is in recuperating, or what is the current status. Now, next thing will be equipments. What are the equipments in the patient itself or surrounding the patient, around the bed? Lines, catheters, warmers, dialysis machines, pacemaker wires, leads present, therapeutic hypothermia is being given, if the patient is having ICP monitor or EVD. So this is a format what we have made. Now you have to also go through the nursing charts, progress charts, lab reports, radiologic images, if they would be providing you in the real exam. Now then you have to guess with the expected questions. You have to, the examiner would ask you, give the summary for the patient and identify the current burning issue. right now for the patient. So this is the normal format that you should keep in your mind. Now, this is a busy slide, but this is the slide of today's presentation for myself. Case presentation, we start with A, B, and C. A is the examination. And guiding principles for the examination is, like in the real practical exam, greet the bedside nurse, introduce yourself to the patient. Mr. X, my name is Y, I am a doctor, I am going to examine you. Look around the patient. We call it normally the examination dance and situational awareness. Look for any machine, that is CRRT, IABP, dialysis machine, EVD, something like that. Already I have told in the previous slide. Look at the monitor. Never forget temperature, EtCO2. If you cannot understand a waveform, that is cardiac output monitoring, ask the examiner what is that value. Look at all the tubes, and the tubes are going into or coming out of the patient, like chest drain, abdominal drain, any other drain, and trace them to the bag. Look at the infusion pumps, then ask maybe the nurse at the bedside, how long the sedation has been stopped, when was the last paralytic dose has been given. Avoid asking unrelated questions to the examiners or nurses, because that will be annoying and that will take your time. You have to be slick and quick. There are some do's and don'ts. Don't do unnecessary things which you also think are useless for a particular patient. Prioritize your system. That means neuro patient. If it is a neuro patient, examine the CNS first. The principle holds true since our MBBS days. Have your own pattern and principle. The guiding principle is, don't do anything which will cause pain or discomfort to the patient without letting the patient know, and ask for the consent of examiners before doing any clinical examination for the patient. Now, second one is B, that is the summary. You have to say in the summary, I examine Mr. X who presented on this day with mild, moderate, or severe TBI, that is traumatic brain injury to ICU. I am giving a like imaginary case. His current issues are, you have to prioritize the case, like the problems right now. He is a post-craniotomy status, still intubated, ventilated with heavy sedation. There are possible issues with raised ICP as evident by high normal ICP with ongoing treatment for it. He is febrile with nil or obvious signs of any septic shock. Fever can be due to neurotrauma. He is currently shocked with an ongoing requirement of vasopressors. And you can also at the same time tell about the differentials, can be, if you are not given a diagnosis at the beginning. And then final on my detailed examination, the findings are ... And the final, the C will be viva. That would be totally the prerogative of the examiners, that they would be taking you to the flow of the questions. Now, let's come to our clinical case for today. It's a vignette 1. You are asked to review a 37-year-old male who has been admitted to your ICU for last 3 days. He is a known case of type 2 diabetic, hypertensive, non-compliant to his chronic medications. He was recently diagnosed with AML and has received induction chemotherapy and was in his 3rd cycle of chemotherapy with cytarabine and midostaurin. He was admitted after a MET call due to shock and hypoxia with rapid deterioration. He had a severe metabolic acidosis with shock, anuria, and was intubated immediately in the ICU for worsening hypoxia. For the history taking, there was a history of fever for last 3 to 4 days along with diarrhea and 1 episode of vomiting. So this is the clinical case or initial stem on which the examiner would like wish you to start the clinical examination and the the viva for the long case. Now, his current clinical status: heart rate is 150 per minute, atrial flutter with 2:1 block, BP 86/46 millimeter mercury, warm and diaphoretic, warm peripheries, temperature is 103 degree Fahrenheit, axillary, on volume SC mode, respiratory rate is 26 per minute with PEEP of 12 centimeter water, tidal volume is 450 ml and FiO2 of 0.9. He is holding or hovering around a saturation of 88%. And on auscultation, he has decreased air entry at left base with bronchial breath sound at left lower zone. This is the current clinical status. And currently he is on infusion of noradrenaline at 60 microgram per minute, which comes to 1 microgram per kilogram per minute with vasopressin of 0.04 unit per minute and IV fluid RL at 100 ml per hour. He is also currently on CRRT with following parameters because of his acute kidney injury and persistent severe metabolic acidosis. CRRT is being done with citrate regional anticoagulation, pre-filter replacement of 2000 ml per hour, dialysate rate of 1500 ml per hour, no fluid removal is going on with post replacement at 200 ml per hour. So this is the current situation. With this background, you may like to ask few other things. What other information you want to know, you can ask. And the lab parameters are with you right now. Full blood count, hemoglobin 7.9, WBC is 500 with neutrophil of 100 and platelet of 8,000. Urea of 129 and creatinine of 2.5, sodium 135, potassium 3.5. And bilirubin 4.3 milligram percentage. ALT, AST is in normal range. Coming to the ABG, patient is definitely having like severe hypoxemia and a lactate of 3.4, bicarbonate of 14, and blood glucose level of 108. Now, the question what I posted on the second slide, the examiner would ask you, summarize your case and what are the current issues in this patient. So when the examiner would ask you, definitely you have to take a pause and frame the sentence with all the important things what you gather from the your history, clinical examination, and the lab parameters what have been given to you. So maybe you can take 10 seconds, 20 seconds, and your answer should be, this is a format. This is not a definitive thing that we are suggesting this format like the examination you should tell in this line, but preferably you should answer in the way, my patient is a 37-year-old gentleman with background illness of AML with recent chemotherapy and is currently shocked with multi-organ dysfunction and fever. His current issues are shock requiring high vasopressor support, multi-organ failure including AKI, that is acute kidney injury, requiring CRRT and probably marrow suppression. He is neutropenic, which makes a neutropenic sepsis and septic shock high on the differential card. And he has currently ongoing fever, which can be of both infective or non-infective in nature, which I may try to explore with further investigation. So maybe this would give you a better impression, and your viva would start with a very positive note. So you can take like this, the summary and also the current issues in one slide. Now, the question number second in this case may come like this. As you talked about fever, what are your differentials for fever in this patient? So when the question will come in a neutropenic sepsis with like febrile neutropenia, so definitely the examiner would like to know what are the other differential diagnoses that are like coming in your mind. So you can tell my differentials are, you can again divide into a structured format. Never jump into like telling about sepsis, then gastroenteritis. It should not be very haphazard. Your answer should be music to the ears of the examiner. And that will give a very positive impression and your marks will be just adding up. And at the end of your long case, you would be almost securing more than 90% of the total marks. So it can be framed like this: infective, non-infective. In the infective, you start from the system-wise pneumonia consistent with current clinical findings. So you have to again prioritize what is right now being given to you. Your patient is having pneumonia, so you should preferably start with pneumonia. Don't jump into infective colitis at the very first instance. So that is not the thing. Normally, the examiners don't like to know or like listen about the thing which you are actually not dealing with right now. You can then start from head to toe, like pharyngitis, dental, this could be pharyngitis, dental infection, because these are all chemotherapeutic drug effect and you may get these complications. Coming to the cardiovascular, CVC, central venous catheter associated bloodstream infection, endocarditis, pericarditis, myocarditis. In the CNS, meningitis, encephalitis, renal or urinary tract pyelonephritis, UTI, prostatitis due to indwelling catheter, gastrointestinal tract, esophagitis, pancreatitis, or other infective colitis. Coming to the non-infective causes, again, you can divide into vascular cause, infarcts, emboli, DVT, pulmonary embolism. Coming to the neoplastic, tumor-related fever that can come in one or two differential diagnoses. Drug-induced and idiopathic inflammatory. Again, that would include acalculous cholecystitis, pancreatitis, or aspiration pneumonitis that has happened in the ward. So this would summarize the question number 2. Now, just for the understanding of our delegates, fever in a neutropenic patient is defined as a single oral temperature of more than 38.3 degrees centigrade or a temperature more than 38.0 degrees centigrade sustained for more than 1 hour. And neutropenia is usually defined as absolute neutrophil count of less than 1500 cells per microliter, and severe neutropenia is usually defined when your ANC is less than 500 cells per microliter. Now, question number 3.
Just a second. I will just pause it there. As we have the esteemed examiners with us, so I would like to know, as a candidate, if I am a candidate, so what they expect as the first opening statement of few statements when the candidate approaches, like what sort of answer they expect from the candidate in the beginning. So I'll ask Sheila madam and Dr. Sumitre, just to make sure that that's what the examiner wants to hear initially as an impression thing from the candidate. What is the one expectation or two expectations that you have as an examiner from the candidate?
Sheila, would you like to start off with? I'll just put in my 2 bits. So Tapas has presented it very well. And as he said, importantly, that present those things that you think are most important in this context. That is the most important. Don't try to, it should be a structured presentation as much as possible. We as examiners also realize the fact that candidates are anxious and sometimes they may fumble a little bit. That doesn't take away marks for you from fumbling initially. I know it takes a little time to build up to a discussion. And as examiners, we kind of try to help you gather your thoughts to get to the point you are trying to make. And try not to impress the examiners immediately. Okay, try to do the right thing. Think of what you usually do with a patient in this situation, present it like that, and look at the most common possible things in that situation. And then only go to the rare ones. By saying out the rare ones, as Tapas said, initially, and trying to think that you are going to impress the examiners doesn't hold good. So I'm sure most of you examinees know that, but sometimes in your anxiety, etc., that happens. Just to repeat the same thing. So that is important to still remember it when you are preparing for it. And one of the most important things is most of the time what you are doing in your ICU, where you are getting trained, is usually the right thing. Will usually be, you will be taking the right pattern of, how to go about investigating, etc. Sometimes we over investigate in a hospital setting because of multiple, save your ass kind of medicine, etc. Having said that, other than that, usually you are doing the right steps, right things. So think of what you would do in this patient in the ICU when you are rounding with your consultant on the bedside. What would you be doing? And that would usually take you to the right way of presenting the most important focus areas, and that kickstarts it well, gives you confidence as you speak, and you can see from the body language and the expression of the examiner that they see that that you are following the right path. So that is very important. And a few things here and there, missing a small little things here and there does not matter. It's okay. Don't get too anxious about it. We also understand the fact that exam is not a natural state of being. Dr. Sheila, would you like to add?
Yeah, I think Dr. Tapas and Dr. Ray have summarized this very beautifully. I just want to give some points when I go as a DM examiner for DNB. See, first of all, you know that the student knows the diagnosis, okay? So you have to do something between, people try to just, present in such a way that they want to just clinch the diagnosis upfront. Now, that's something that's not expected. And at the same time, you shouldn't make it so long drawn out and irrelevant. It should be something like the snapshot you give the consultant on the round. When a consultant comes to, in the ICU and says, okay, what is happening with this patient? You know, the resident that can give you an absolute crisp, brief summary, and that's what's expected. So and the other thing is, though you know the diagnosis from the history, and even if you haven't got it from the, the way the case is progressing, and I think it was very nicely put together. I think what is expected is structure. And that is often what is lacking when because people just start saying, oh, his lactates are so much, and this is, like, don't talk in that way. And I would say maintain eye contact, just give a few seconds, don't just start vomiting out the answer right away. And so the examiner feels that you are putting together all the information that you have assimilated and putting it together to try to clinch the diagnosis. So I think that's very important, and the structure is very important. You must move from your history to your examination to your clinical investigations. I don't like it when people straight away start talking about investigations and lactates are so much and X-ray shows this. First talk about the history. So and then you say, based on my, my clinical examination, the history, clinical examination, and the labs that are available to me, the probable diagnosis is, so it should be structured. But sometimes it's very irritating to see some students, like they will just go from A to Z and every system and every, because that is very irrelevant. In critical care, we have very less time. So we want, something that is a quick summary. We don't want everything from when the patient came to the hospital. Like Tapas very beautifully said, this is a case of AML, post-chemotherapy, it starts from there. It doesn't start from, oh, patient had pain in abdomen, then he presented to the hospital. And it is, that all has to be skipped, because it should be very specific to his critical illness. So I think it's just very beautifully, put together by both of them. But I just feel the structure should be there without being too detailed, and not just going straight away to the, to the diagnosis. Because once you start talking only about one system, the examiner gets the feeling this person already knows that this is the thing. So you should cover every system. Like this is a typical cancer patient, neutropenic sepsis, there could be mucositis, there could be other reasons, the other causes of, infectious and non-infectious causes. Many of them have PICC lines, so there are bloodstream infections, there are other causes, not necessarily the pneumonia. It could be a combination of 2 or 3 organ infections. So, you must give the examiner, the impression that you are doing a thorough examination and you are ruling out and trying to narrow down your, whatever information you have in order to clinch the diagnosis. So that's just what I would like to say.
Yes, ma'am. Thank you, ma'am. And sir, beautifully summarized. And these are the golden words from our examiners at the national as well as international level. So moving forward in our case, the question number 3, the examiner right now is showing you the current chest X-ray. And now he's asking you, will you be able to narrow down your diagnosis? So with the background of AML, chemotherapy, and the neutropenic status with high-grade fever. So now after looking at the X-ray and with the background history, I would narrow down my diagnosis to neutropenic sepsis with shock due to left mid and lower zone pneumonia with multi-organ dysfunction. So this would be in one line my summary for the this case. Now, question number 4, moving ahead, the examiner would directly ask you, how will you further manage this case? Because this is right now the patient is sinking down. So definitely you need to be really right now proactive in your management. So I would start with the major important issues right now in front of me is optimization of the ventilation, optimize the blood pressure, ensure further septic workup has been done to rule out the infective focus or it is non-infective focus. And I have to start early empiric broad spectrum antibiotic at the earliest. So as per the recent guideline, in a case of neutropenic sepsis, when the patient is in like a refractory shock, definitely every second counts. So I would be having these 4 important points in front of me that would take me hardly 5 to 10 minutes to do. So that these are the things which are right now of prime importance to me. Now, Question 5, after your
Sorry,
answer.
Tapas, just
Yeah,
sorry
yeah,
to
ma'am.
interrupt you. One thing, because you were showing me the X-ray just coming from a cancer hospital. Remember in neutropenic sepsis, I mean, it's very good that it's very obvious the diagnosis, I mean, you know, the findings on this X-ray, but remember that X-ray has very limited value in neutropenic sepsis, okay? So when you have a patient who has an absolutely clear X-ray and has respiratory symptoms and has fever, and you cannot find any other source, remember, you must talk about doing a CT scan for this patient, because in neutropenic patients, X-ray actually has very limited value. So just keep that in mind. Yeah, thank you.
Thank you. You can also do POCUS at the bedside to rule out like any other thing you are dealing with. Maybe could be it is pleural effusion or like anything which is not in your like prime diagnosis or differential diagnosis. Now, how will you further manage this case? So I have already discussed. Then the question number 5 would be to the first point which you have mentioned. So you have mentioned about optimization of the ventilation. So the examiner would take the clue from your like the first point and would start with, will you be able to elaborate each step of management as you mentioned, starting from ventilation? So your answer should be, I would optimize ventilation targeting the most important things you need to tell. You cannot say about the rare trial like things what has been mentioned in some 1 or 2 trials. So it has to be evidence based. So you have to tell all the things which are evidence based. So plateau pressure less than 30 centimeter water, lung protective ventilation, driving pressure less than 15 centimeter water, accept permissive hypercapnia. And I would also optimize the fluid balance to keep the patient fluid neutral to negative fluid balance after initial fluid resuscitation. So this would be your like the examiner would like to know the basic things what we normally do in our ICU, rather than some like rare things may be done in like the rescue strategies. But when you start with the basics, you should start with the evidence which is for like for last 20 years people are doing like this. So maybe your answer should cover the important points. What are your rescue measures for refractory hypoxia in this case? The next question straightforward would be that how will you manage this refractory hypoxia when you're like the pH is 7.2 and your PO2 is 55 on FiO2 of 0.9 with PEEP of 12. So again, that would be divided into ventilatory measures, non-ventilatory measures. So your answer for every question should be structured. It cannot be like from neuromuscular blockade, you can directly go to the I ratio, then you would go to the sedation vacation or like heavy sedation, fluid management. So it will be also easy for you to like go ahead with the answers stepwise. So if you will start with ventilatory measures, you can go ahead with the answer, increase the PEEP further if hemodynamics permit and if there is improvement in the oxygenation. Sorry. Further recruitment maneuver, increase the I ratio, I is 1:1 or inverse ratio ventilation, accept permissive hypercapnia for a pH of 7.20, consider prone ventilation, though it is a localized pathology. Coming to the non-ventilatory measures, your answer could be neuromuscular blockade, improve survival, not just gas exchange, minimize the dead space ventilation, remove as much as tubing as you can, low carbohydrate, high fat nutrition, sedation that will decrease the energy expenditure and improves ventilator synchrony for at least 24 hours to 48 hours. Fluid management should have a goal of neutral balance. If all the things are not doing job, then you can consider putting the patient on VV ECMO. Anything, sir, from your side? What should be the answer or like in for this question?
Yeah, so I mean, the whole focus of this presentation is how to go step by step. So not intervening too much about the management, but just a few things. Probably the examiner in a patient in shock would be looking at fluid resuscitation earlier than the ventilatory management. That would be one thing. The other is that, as DRNB students, DM students, IFCCM students, we expect them to know the major relevant studies and sometimes the really recent studies which differentiate certain things, like neuromuscular blockade. You say improve survival. Well, there's a study which shows that it can go either way. I mean, different studies have shown. So there is probably we would be happy to hear, if they can, that yes, you can be a titration of neuromuscular blockade rather than a continuous 48 hours, depending on the setting, etc. So studies based on that. Then the sedation. So the point is that whenever you are committing yourself to something, so when you say a low carbohydrate, high fat nutrition, then the examiner at your level of as an examinee will be asking, what is this based on? Which is the study it is based on? Do you know the study? Why do you say that? Whatever you say, if you are committing yourself to something at the level of a DM or a DRNB examinee or an IFCCM, you have to have some evidence or good paper on which you are basing it, which may not be common practice. It is possible that you may differ a little from what is the usual practice, but you have to convince the examiner that the possibility that this can be done in this setting is based on what evidence you have studied. That, so whatever you say there, you have to back it with some degree of evidence, which may be contrary to maybe even the guidelines. But you can say that, this latest study showed that probably that this would be better, even though the guidelines yet have not accepted this. So that is important. Whatever you are saying, for every point that is there, you have to have evidence behind it.
Yeah, I just like to add, I think Sumita summarized it very nicely. Whenever you make these points, it's good to make these points, but don't put your foot in, okay? So if you're not, if the moment you say prone ventilation, you should know about the PROSEVA trial. So you don't have to know each and every study on that, but you should at least know the big trials, and you should have a summary of the evidence, because otherwise, or you should know at what cutoff values you are expected to prone the patient, like say 150 P2F ratio. I would not say something like further recruitment maneuvers, because that will open a whole Pandora's box and get into controversies, because now we recommend against recruitment maneuvers. So I would put that little lower down on my list. So I'm just saying what you're very confident about, talk about that and pause. So the examiner will ask you about that. Say, I would try prone positioning. So, as your, and even your PEEP, what kind of PEEP, then they'll go on to setting PEEP in refractory ARDS. If you talk about neuromuscular blockade, at least you should know about the Accuracy trial and the recent ROSE trial, where like Dr. Ray said that, there isn't a role for what we used to do is 48 hours of all the previous trials showed that 48 hours of continuous neuromuscular blockade would be given, there was a benefit, but the ROSE trial actually showed no mortality benefit. So you should at least know, these major trials, and don't put your foot in if you're like with low carbohydrate, high fat, unless you know the studies. I would put that much lower down on my list, or pause and wait for the examiner to go on to that trial, so there's a way to leave the examiner, isn't it? So that itself is an art. So I would strike a balance here rather than just list everything from A to Z. But it's nicely summarized.
Just one more thing. Again, like examinees are not a homogeneous mass. No, neither are examiners a homogeneous mass. Different people. I mean, there is a broad pattern of how we look at things, but there's a slight differences also. That so, like, I'm not trying to it's a good thing or a bad thing. I'm just saying, like, if you go contrary to what the general opinion is, but you quote studies and you understand the pathophysiology behind what you are trying to say, it may be counter to the present kind of guidelines or whatever. Right. I mean, classic for me is the role of CVP. Not as I'm not saying yes or no. I'm just saying role of CVP. What has been pushed at a certain point, what somebody else feels based on the pathophysiology, looking at the right atrial pressure. If you have a good physiological understanding of where it can be used, you may say, but you need to be very, 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 very clear in the pathophysiological or physiological understanding on the points where you go counter to what the present guidelines say, right? So if you go that way path, you have to be even clearer than when you are following the guidelines.
Yeah, absolutely. And one more, in fact, I like an argument against, someone challenging dogma. Yeah, if they have a good physiological explanation. One point I'd like to make is I would evaluate the candidate not based on, how much knowledge they have or how many of the trials that they know. I would see that how well they are able to, use the information that they have and go in the right track to clinch the diagnosis. This is very important because it tells you how organized the person is, how well their thinking is, and how well they're able to get the clinical information, even though they may get a wrong diagnosis. That's not important. But are they, is their approach systematic? That is very important for me to know. You know, are they systematically evaluating everything and then trying to get the diagnosis, rather than just saying, okay, this patient has this and there's a patch on the x-ray, so this is a pneumonia, and not looking at anything else. So I think just a systematic approach would make a candidate for me score much above any other candidate who's got the right diagnosis or knows a lot of the literature, just knowing the literature.
Yeah. Thank you. Thank you. And then the flow of the question number 7, as already told by Dr. Ray as well as Dr. Maitra Madam, will you be able to go through available evidence for proning, recruitment maneuver, and neuromuscular blocker in the management of hypoxia or ARDS? The question is straightforward. For proning, definitely you need to know about ProSEVA trial and 1 or 2 line about the ProSEVA trial. It's a multi-center randomized control trial with severe ARDS patient, prone positioning at least for 16 hours, significant improvement in 28 and 90-day mortality. And there is then the next one is neuromuscular blocker. The positive study is accuracy study, and the negative study or equivocal study is the ROSE trial recently published. So again, accuracy study, 90-day mortality was significantly lower, less barotrauma related complications, nil significant difference in the ICU acquired weakness. In the recruitment maneuver, ART trial, higher mortality at 6 months, higher pneumothorax, and less ventilator free days. So you have to
just to tell you, very nicely put. So just to go to recruitment, right? So if you catch somebody who's anti-recruitment and you say that as a second point, you can be in a lot of trouble because it'll just push you to the art trial. It will push you to the controversies. So I would rather put ProSEVA higher. I would put proning. I would put PEEP. I would put these kind of things and play safer. And then if the examiner, what else can you do? Whatever you can say, it's a bit controversial, but in select patients, a recruitment maneuver might help. So you have to be very diplomatic in the way, again, depending upon who, and you know, you can also examine your examiner, right? So when you answer, you can see a few questions that are asked, you know, the way the examiner is, and what is the depth of knowledge of the examiner also you can gauge. So based on that, you can also leave the examiner. So that is why you see, based on this art thing, I would not put that as number 2. I would put that much lower. I would put ProSEVA much higher. So, and you know, you give very specific things like, you know, when you give a stepwise approach to how you would handle refractory hypoxia. So don't talk about proning without having tried neuromuscular blockade, without having, increase the PEEP or FiO2. And then you would say, I would, you know, when the P2F ratio goes below 150, I would prone the patient. And despite this, if the, the P2F ratio goes below 80, then I would consider ECMO. But if I'm still not able to maintain lung protective ventilation and, you know, my goals, then I would even consider ECMO earlier. So you must have a very nice stepwise approach to how you would handle refractory hypoxia. Rather than listing the points, I would like to know that kind of approach. Not that I'll also do ECMO, I'll also do this, I'll also do that, because that is somebody who's not very clear in their thought, and I can imagine how they're managing the patient. So what I would say is your examiner, when you're talking, should get an idea that this is a person who's handling this patient very, very safely in the ICU. You know, he's a safe person to leave a patient with. That is what they want to know at the end when they decide whether to pass you or fail you, or then of course, you know, give you the best marks.
Just to add, I mean, not to debate, just guidelines. If you're talking about what it says is that do not use maximal recruitment strategies. It doesn't say don't do recruitment strategies. It says do not use maximal recruitment strategies. Yeah.
Yes, thank you. So the question number 8, as the next step of management, how will you optimize his SOC? The respiratory part you have already tackled. Now coming to the SOC part, knowing that he's already on a high dose of noradrenaline and vasopressin. So what are the other rescue strategies you have right now? So the answer could be around like the fluid therapy, quick assessment of the fluid status with the dynamic parameters such as pulse pressure variation or stroke volume variation or assessment of inferior vena cava distensibility index. I would also go ahead with judicial fluid loading, looking at the response after the initial resuscitation period. Then I would also consider optimizing the cardiac function by ruling out any cardiomyopathy, whether it is septic or pre-existing cardiomyopathy. And at that point of time, I would also consider inotropic agents Maybe it is adrenaline, dobutamine, all a sort of milrinone. Coming to those medications, switch over from the sedatives and analgesics from a cardio like unstable efficacy to the cardio stable agents. And also I would add steroid if not on already. So this would be the part for the shock, how to optimize, and the answers, the preferred answers would be fluid therapy, optimizing the cardiac function, and the medications. Now, question number 9, as you have already discussed about the steroid part in the last line in your question number 8, the examiner would like to ask you about further steroid question. Please tell us about current status of use of steroid in sepsis and septic shock. So definitely you need to back up with the evidence. Now, the most important trials right now, which is coming to me for the septic shock management for the steroid. First one is Survival Sepsis Campaign 2021. It is a low grade recommendation in favor of low dose steroid in septic shock, but definitely early resolution of shock and more vasopressor free days. So that you have to start with. Then the most important trial published in 2018 in NEJM, Venkatesh et al. Adrenal trial. And this is again a multi-center randomized control trial, which showed that there is faster resolution of shock without any adverse effect on the mortality and length of stay. Coming to the approach trial, that is again published in NEJM 2018 by Anand et al. And the study included hydrocortisone as well as fludrocortisone, and definitely the 90-day all-cause mortality is lower. But definitely there are other negative points for the study. But yes, for the steroid part, for the septic shock, the 90-day all-cause mortality was lower. So you can quote these 3 trials if it is being asked related to the steroid. Now, the question can come straightforward. What are the... Yeah.
Sorry. If I could just go back to the part on shock, the previous slide. Yeah. The previous one. Yeah.
On resuscitation. Yeah.
On resuscitation. Yeah. So I think here it's very important because your patient is on very high dose vasopressors. And I think, the criteria one would expect to use at the bedside. It is not that just because the patient has ARDS, you don't give fluid to the patient. Okay. So in this kind of setting, this is a very, very risky situation to give any kind of fluid. So before giving any fluid, you have to assess fluid responsiveness, as you rightly said, using PPV, SVV, and IVC variability. So I would say the first is to decide, because a lot of times these patients are on very high dose vasopressors when actually they need fluid. So you need to assess fluid responsiveness. So the question I would ask, the 3 questions I would ask at the bedside is: 1, is the patient in acute circulatory failure? And the answer is yes. The second is the patient fluid responsive, which you would know from these tests. If the patient is not fluid responsive, there's no question of giving fluid. But what's very important to remember is that even if the patient is fluid responsive, what you have to know is whether there is any risk of giving fluid. So your patient may be fluid responsive, which you mean the cardiac output will increase after giving fluid, but you still won't give fluid to this patient because the risk is more than the benefit of giving fluid, and you'll probably step up the vasopressor. Now, how would you know about the risk? So you would consider, in this case, if the examiner asked you, you would consider doing advanced hemodynamic monitoring in this case, because this is a patient in shock with ARDS, and this is the most difficult condition to treat, because you need to know, you can do more advanced, if they ask you, you can do more advanced hemodynamic monitoring, which parameters like SVC, SVV, PVV won't tell you. And these are, parameters you can get, using a PICO or a flow track, what do you call it, volume view, where you can get the extravascular lung water index, you can get the pulmonary vascular permeability index. So if my extravascular lung water index is low and my patient is fluid responsive, even if the patient has ARDS, I will consider doing fluid rather than going up on vasopressors. On the other hand, if my extravascular lung water index, the cutoff value is somewhere like between 7 to 12 is normal. So is like say 16, and my patient is hypotensive and fluid responsive. Despite being fluid responsive, I will not give fluid. So you must at least say that at this point, I would like to do some advanced hemodynamic monitoring, because I would like to look for risk of, for the risks of giving fluid to this patient, because to distinguish whether I should give more vasopressors or give more fluid, which is really the dilemma in this kind of situation when you have a patient in shock along with ARDS. So I like to emphasize on that bit, and also the things that you said about sedatives, rather than propofol and midazolam, I would give opioids to this patient, because plus minus sedation, you can just give opioids to the patient, because propofol will again cause hypotension. This patient must have been already 4 or 5 days on the ventilator. You don't want to give more than 48 hours of propofol because of concerns of propofol infusion syndrome. And midazolam continuous infusions are a big no-no, because it's an independent risk factor to transition into delirium. So you have to think about, these are just things that an examiner I would just see midazolam and I would catch on that and start asking about delirium, or, start asking about the sedatives. So when you're listing these things, I just want to say that be very careful what you're saying. And your approach is important, not whether you may not even have that advanced hemodynamic monitor, but that approach, what is your thinking? What are you thinking next? This is, shock on very high vasopressors, and you don't know whether you should give more fluid or you should just go up on the vasopressors. So I would expect that kind of answer where, the person is going in that right track with the hemodynamic monitoring. Yeah, I just wanted to comment.
To add, I'm not making a comment on the right wrong, but whenever you comment on a methodology of resuscitation, this is the pulse pressure, the dynamic measure, etc. Always know the caveats of every monitoring system.
Limitations, yes, of course.
Yeah, limitations, caveats, because whatever you use, there will be caveats. So you need to know that. The examiner will take you next to that. Okay, pulse pressure variation, stroke volume, what would be the caveats? Why would be the problem? So remember that all the limitations and caveats also. Dr. Sheila, as Dr. Sheila said, yes, progressing to more advanced monitoring probably, but there will be examiners who will say, okay, you have only limited, you have an arterial line, you have a central line, whatever, and you have your ultrasound. What would you do? What are the possible in a limited, resource limited area? Where would you go? How would you use that? The combination of these factors. So it can go either way. So hemodynamics, ventilation, antibiotic, these are, certain elements are absolute. Every debate, every major article, every debate that is in the sedation, anesthesia, delirium, these are the major debates. You need to know both ends of the argument. Okay, you can't escape with just having one view, that this is the only view, because the debates are still on, and which is a good thing. So you need to know the debates, the major debates which are going on in these fields. And this is basically looking at DM, DNR, DRNB and IFCCM, where we are looking, one is safety of the patient, but also we look at you as the future teachers, researchers, etc., who have that level of knowledge, who basically can take on the examiner. Actually, I'm looking at a candidate who's taking a DRNB or a DM, who can actually take me on the physiological and pathophysiological understanding of disease. When they reach a certain level of safety of taking care of the patient, that's the next level you are looking for.
So I think Sumit's made a very nice point. And like he said, rightly said, nothing is black and white. And whatever stand you take, you should be able to justify that to the examiner. Okay, if I say I give dobutamine, I should be able to justify that. If I said, no, I won't give fluid, I should be able to justify that. So whatever is what you do, you should be able to justify that. And a very nice approach when you deal with a patient in shock, not even a patient who's not in shock, just in respiratory failure. Any patient who comes with any cardiovascular or respiratory insufficiency requires both heart and lung ultrasound. You need to do this, okay? Even if a patient, so you must comment on the cardiac function, because a lot of patients who come with pneumonia, they have sepsis-induced myocardial dysfunction. So you wouldn't just go on and on giving them lots of fluid. I mean, you need to assess the cardiac function. So that's something examiners really like to hear when you talk about assessing the cardiac. Anyone who presents in respiratory failure should have an echo, not just someone who presents in shock. So that's a very good approach to respiratory failure and circulatory failure, to do an both lung and heart ultrasound to rule out cardiac dysfunction. So I think that's very nicely put up, and then he's talked about cardiac optimization of cardiac function. Yeah, sorry Tapas to go back, but I just thought we should talk about hemodynamics.
Thank you for this clinical pulse, and definitely these points would help the candidates to prepare in the next 1 month or so. So now moving further in our case, the question number 10, what are the other common indications of use of steroid in ICU? So it's not only related to sepsis and septic shock. So the examiner would like to know about where, like the other conditions where you are using steroid. So again, you have to start with the structured way. neuro, bacterial and TB meningitis, vasogenic edema, septic shock, which you have already mentioned, catecholamine resistant, respiratory, ARDS, post 7 days, pneumonia, COPD exacerbation, asthma, acute airway edema, post extubation stridor. Coming to the renal, autoimmune nephropathy, critical illness related corticosteroid insufficiency. Coming to the endocrinopathies, where you are telling about the thyrotoxicosis, thyroid storm, myxedema coma, adrenal insufficiency, autoimmune disorders, microangiopathies like TTP, HUS, and in the GI, it is inflammatory bowel disease, autoimmune hepatitis, post-transplant, and alcoholic hepatitis. So if a question comes like this, it's a straightforward answer. So you can mention about the system-wise. And these are the indications for steroid with the dose and duration. Just keeping forward, coming to the question number 11, coming to our patient, this is a case of immunosuppressed host. So what are the organisms you are suspecting at this point of time for his pneumonia? So for this question, you can start with commonly a cultured organism divided into gram-negative bacteria, gram-positive bacteria, other bacteria, fungi, then less commonly cultured organisms and additional organisms. So I'm not going into detail, but yes, you can mention about the most common gram-negative, gram-positive, and fungi. Now, coming to question number 12, enumerate the investigation plan for this patient. How will you investigate to reach a diagnosis and your further management? Again, start with a structured way. Blood, I would go for the WBC and your neutrophil count, platelet hemoglobin, RFT, LFT, CRP, procalcitonin. Coming to the microbiologic part, I would send blood culture sensitivity, minimum 3 the pairs sera, aerobic plus anaerobic, atypical bacterial serology, sputum, ET secretion, urine for the streptococcus, legionella antigen. I will do BAL sample, respiratory viral PCR, PJP stain, fungal stain, AFB stain, galactomannan, stool microscopy and culture sensitivity because it's a immunosuppressed and the post chemotherapy patient. Radiologic CT chest, when able to rule out any abscess, collection or specific findings with infection like fungal ball, halocine, because it's again immunosuppressed, aspergillosis chance is very high. 2D echo at this point of time, you have already done POCUS, but yes, I would go ahead with the formal 2D echo to assess the cardiac function and rule out any infective cause such as infective endocarditis. So this is again a normal template where you are touching upon all the important investigation of the modalities you are having. Question number 13.
One point on the very nicely outlined and very good plan. Just one point on the urine examination, because this patient is neutropenic. So whenever you have a neutropenic patient, urine examination, you should specify to the microbiologist that this is a neutropenic patient, because when you do the routine microscopy, they don't see the cells, pus cells, so they don't process the sample further. So it's very, very important that you specify that the patient is neutropenic, because in a neutropenic patient, they will always process the sample further. So just something to keep in mind. Yeah, thank you.
Yeah, thank you. Now coming to the question number 13, straightforward. Now you have investigated. Now what is your empirical antimicrobial plan? So if the question comes like this, I would start with carbapenem to cover gram negatives like Pseudomonas and anaerobes, as well as to work synergistically with vancomycin. Add vancomycin as gram positive coverage, MRSA coverage to cover beta-lactam resistant gram positives. At this point of time, I would go ahead with caspofungin to cover Candida species, which might be resistant to fluconazole, such as Candida glabrata. Voriconazole might be substituted if pulmonary infection is suspected, and in my patient, definitely it could be pulmonary infection, pneumonia, where caspofungin doesn't penetrate very well. Amphotericin might be substituted if one wishes to cover even more broadly, that is zygomycetes or cryptococcus. Ganciclovir I would add to cover cytomegalovirus, and also trimethoprim sulfamethoxazole to cover pneumocystis jirovecii. So this would be my empiric antimicrobial plan. Anything, sir, at this point of time? Ma'am, anything?
To add, just go back. I would put a, put carbapenem and probably vancomycin, but I would hold on with the antifungal. But if the fever persists, then I would add an antifungal. So it really depends on the setting. I wouldn't start with all of it, but I can give the rationale for it. Like if you're expecting, candidemia, or you're expecting aspergillus or something, then I would add it. But otherwise, see, this is neutropenic sepsis, so you've got to get it right the first time. But I would not do this. I would not carpet bomb him right from the beginning. I would start with the carbapenem and vancomycin, and then if the fever persists, because there are very specific guidelines for antibiotic prescription in neutropenic sepsis. So you escalate as the fever. If the fever persists, then you add an antifungal, or you could add a dual antifungal therapy, and then you send your tests. And if it's CME, then, or if you're suspecting pneumocystis, then you will add. So it's not like everything together. I would not say that.
So, I mean, I don't want to add to anything in the treatment because I know this is just a representative case, and many different kinds of cases. So, but very well put by Dr. Sheila and Tapas. The thing is that whatever you say, as I said repeatedly, justify it. Second is, you can always discuss with the examiner and say that this is your viewpoint. Okay. But also learn to look at the patient of the examiner's body language. Don't be combative. Debate, but don't be combative with the examiner and start saying, so you have to be argumentative enough without being combative. Because if you believe that you have the possible setting and the evidence to propose a certain line of treatment, you should carry it forward with a certain, a very with a nice way. You debate the situation, and I think most examiners like a good debate because nobody knows everything, about the patient, and how to go about every point is not completely set. And that is why critical care is so exciting. There are so many things to debate, but don't become combative. There may be an examiner who believes that, no, he or she believes that would be the path, who becomes set in what he or she is saying, then step back, say that, okay, possibly, but I would have thought like this, but maybe. And then step back. So don't become combative with the examiner, but always debate is acceptable at this stage.
Yeah, but more than debate, I would say justify. You're not wrong. You may have a different point of view, but you should be able to justify. But definitely, like Sumit said, being combative is the best way of wanting to, getting to fail. So just don't do that. And I like the way Tapas has, put in everything here on the slides. So because this is the common things that you would do in common drug prescription in neutropenic sepsis. So at least he's, each and everything, the justification is there. So that's very nice, because you might add on a few, you might start with all together, but at least everything is there, that what are you using this for? What are you using this for? So that's very nice. I think this summarizes it very beautifully.
Thank you. For the justification part, if the examiner wants, I will be making it simulating for the caspofungin. Maybe we can have a discussion like this patient is in having refractory shock with highest dose of noradrenaline and vasopressin, and the patient is having multi-organ dysfunction. So maybe I won't lose any further time, and I would start with the gram-positive, gram-negative, antifungal, antiviral, and atypical. So maybe my answer would be, if the examiner wants, then you can always explain in this way.
You can say that this patient is just too sick, is really sick and in refractory shock. And, so you can justify your antifungal upfront and also antiviral. One more thing I want to say is, in this kind of patient with multi-organ failure, it may be worth considering, instead of capsofungin, you can even consider anagilofungin, because this patient, a lot of times they have renal and hepatic dysfunction, and anagilofungin is not metabolized in the liver or in the kidney. So it would be a safer agent to use in this kind of setting.
Yes. Very well taken. And then moving further, question number 14. Now the sputum culture is right now coming to you, and it is positive for Pseudomonas aeruginosa, which was sensitive to piperacillin tazobactam and meropenem. He was continued on meropenem. His shock resolved rapidly, but on day 5, he landed back on noradrenaline with neutrophil recovery to 4,000. His shock got worse, requiring vasopressin and noradrenaline at again higher dose. His repeat ball showed Pseudomonas, which was still sensitive to meropenem, with a new gram-negative pending identification. So what is your further plan? So the question can come like this to check whether you are thorough in the antimicrobial culture sensitivity report study. Now, you can always answer like this. It's a case of non-resolving pneumonia and other causes of ongoing or new sepsis need to be considered. I would investigate further with BAL sample sent for culture sensitivity, PJP stain. Already this has been discussed. I would upgrade at this point of time to colistin IV as well as nebulized, and change antifungal to amphotericin B to cover for aspergillosis. Maybe
Just one point
the
to
answer.
add, one point to add, the person, this kind of case, especially day 5, when you're seeing that the patient is worsening, line-related sepsis would be very high on my cards, other nosocomial infections, right? So bloodstream infections would be very high on my cards. This patient would have a central line, 5 days have already passed. So at that point, the blood culture may have been negative initially, but this is something that, because the pneumonia kind of distracts you, and you only think that it's a non-resolving. But remember, very high on your card, this patient will often have a PI spic line along with the central line and art line and many other invasive catheters. So you have to be, and this patient is neutropenic, right? So I would also keep that in mind.
Yes. Thank you. And now coming to the question number 16, what are the causes of non-resolving pneumonia? Very straightforward question. And again, it has to be structured. Like if you have opted for antibiotics, which are inappropriate for that patient with regard to the dose, route or organism. Coming to the organism related, infectious but not typical, like you are dealing with some resistant organism like Stenotropomonas or Acinetobacter. Intracellular organisms like Legionella, Mycobacteria, Chlamydia, fungal, Aspergillus, Cryptococcus, protozoa and parasitic like Toxoplasma, Schistosoma. These are more relevant in the immunosuppressed and on chemotherapy drugs, the patients, and also viral pneumonia. So you may have to tell about the rare causes that we normally don't consider, but in this population of patients, definitely these are of more relevant. Now, they may change right now from the pneumonia and the sepsis, septic shock and the steroid to a different aspect which the patient is on, that is CRRT, to check whether you are thorough in the bedside management of these patients on renal replacement therapy. So now they may ask you, as you have described earlier, he is on CRRT. Will you be able to narrate the complications associated with initiation of CRRT? Now, again, it has to be structured like line related, hemodynamic instability, electrolyte abnormality, temperature related, hypoglycemia. So very straightforward answers I would be skipping because for the paucity of time, I would be going ahead with the next question, again related to CRRT, to check your nephro critical care expertise, and they will show you something like this. What is happening here? This is the alarm flashing on the monitor. What can cause this? So to check whether you were attentive during your training period in the ICU at the bedside, have you started any patient on CRRT? Have you checked any troubleshooting and you have done something to rule out the complications or the alarms on the monitor? And if you are thorough at the bedside, you can answer it pretty well. And you can start with what are the causes of low pressure access. That is, you can again divide into vascath related, flow related. Vascath related, it could be due to vascath is kinked, line is kinked, vascath is shocking against a vessel wall, the vascath has become occluded with clot. Now coming to the flow related, the blood flow to the vascath is poor or the patient is actually hypovolemic and you need to give bolus fluid. How will you manage a low access pressure alarm? Just for the final question, the examiner may ask you related to the nephro part. You have to answer like, I will check the circuit, and this has to start from the machine, work along the circuit, checking for any kinks, check the vascath for kinks, ensure that it has not been become dislodged, pause dialysis for some time, aspirate the vascath lumen, trying to suck out the clot if there is one. Then you have to, along with checking the circuit, you have to check the patient, ensure that this patient is not agitated, hampering the flow. That is one of the most common cause. If the patient is coming out of the muscle relaxant effect, correct the hypovolemia part, because that is again, you can do immediately at the bedside. So with that background, almost we have covered the initial summary, then the clinical examination part, then the most important burning issues for this patient, then respiratory hemodynamics, then drug related, then ruling out any other like non-septic cause, and finally ending up in the nephrocritical care. So this is a pro forma which can be asked. A similar question, like set of questions can be asked in your real exam. So I thought of putting the atypical case, that is immunosuppressed host with septic shock. Thank you all of you, and I think if there is any queries from the candidates, Dr. Sanand, you could address, and our mentors would be helping me.
Very nicely done case, huh? And I like the way you led the discussion, Tapas,
Thank you,
and the questions that were asked. Yeah.
I think there is one question in the chat box about dual anti-pseudomonal antibiotics in patient, or especially in neutropenic patients. So, ma'am, what's your take on that dual anti-pseudomonal cover for neutropenic sepsis with a proven
that's
pseudomonas?
what we see. It again, it's not about the bug; it's about how sick your patient is. That's very important. You know, the clinical context is very important. So don't just try to treat the microbiology report. So very often we don't have a dual cover often. But if a patient is very sick, like I'm saying, the choice of drugs that Tapas showed, sometimes we start the patient on all those drugs all together because the patient is too sick. And if your examiner says you are giving covering for PCP or covering for, because this patient is so sick, you got to get it right the first time. You can't, so you can justify it. But on the other hand, if the patient wasn't in such refractory shock and wasn't, then I would hold on with adding on the other things like, for CMV and for PCV and things like that. So my argument would be the same. It really depends on the clinical context. There's no hard and fast rule that, you have to add, double pseudomonal cover.
This anti-pseudomonal cover in a patient with such severe shock and neutropenia, I would give dual cover.
In this patient?
Yes, absolutely. Absolutely. Because the setting, as you said, Sheila, that the setting is such that the patient is in shock. Second is just as Tapas showed very nicely, that piperacillin tazobactam sensitive, meropenem sensitive, but meropenem was continuing. And the reason for that is, again, the evidence. There are 3 major trials which have shown that in spite of piperacillin tazobactam sensitivity being positive in a patient of Pseudomonas or any other or Enterobacter C group, mortality was always higher if piperacillin tazobactam was used as compared to carbapenem. So you can always justify continuing and not de-escalating in this patient who is sensitive to a BL-BLI combination as compared to a carbapenem. So, I mean, as I said, I mean, more a general picture of, because each case will be different, is that these things you have to know to justify, right? Sanant, you want to add anything?
One thing I wanted to say, that even if you say you're going to add all this, always say this patient is very sick, so I'd like to add all these 4, but always talk about de-escalation. You say the moment I get my reports, I'm going to narrow down my spectrum. So that's very important. So then, the examiner gets the picture that, okay, he's not just carpet bombing and, starting everything that he has in the armamentarium. So your thinking is, he's very sick. I don't want to take any chance. I'm starting him on whatever I think may be the, bug, and then I'm going to de-escalate. So I think I would like that to come along with, saying that I'm going to start all this, justify because he's very sick, and say I'm going to de-escalate as soon as I narrow down the spectrum. I'm going to, stop a couple of these drugs.
I completely agree with that approach. Yes, sir. Actually, that's a trick question for my trainee. Why I'm giving meropenem instead of peptides if it is sensitive to peptides?
Yeah. Many people get fooled by the positive report, but I think Sumit has a very good point, because otherwise people say, oh, there's sensitivity to Cipro also, there's sensitivity. So don't get fooled by this. And another very good thing is, when you have a very sick patient like this, it's really worth talking to your microbiologist often.
Yes.
I'm not saying that very good support. But we as intensivists, we just think we know everything, and that's not the way. You should say that this is a difficult to treat infection, and not all hospitals have ID specialists, but you could even talk to your microbiologist. I often pick up the phone and talk to microbiologists, and they give you a lot of, they say, no, okay, this culture, this is a clinical condition, this is what is happening, the patient is not improving, but these are positive, this is the MIC. So they say, no, don't give this, you should continue with meropenem, or you should do, so that input also is very, very useful.
All right, Tapas, we are slightly behind time, so we should be quick with the next one.
Sorry.
Yeah. So I would invite Dr. Mona Lisa to start with the table viva, and we'll start with ECG. We'll be making 10 to 15 minutes for each table. So we'll fix in next 15 minutes or so. Yeah.
Oh, you have tables as well. Okay. That's not a
Yes. Dr. Mona Lisa, are you there?
Hello, sir. Hello, everyone. That was a really good long case presentation. And so the problem in the exam is also the same, that we have very good long case presentation because everybody is so awake and so alert in the morning after their breakfast, and the adrenaline rushes high. But like afternoon, all the adrenaline comes down. You have had your lunch, you feel sleepy, and after that, we sometimes make a few mistakes in table viva which we would have ideally not made. So we sometimes don't score as good as we score in our long cases. So just to keep our adrenaline levels high and the excitement going on, we should be like, cracking on the table vivas with the same excitement like we crack on the long cases, because they're very, very scoring, especially ECGs, radiologies, they are very, very scoring, and we should all, try to attempt them with the same level of excitement which we attempt all our long cases and short cases. So with that, I'll start with my table viva. I'll present my screen. So today we are not going to teach you, ECG, radiology, and all the ventilator graphics. We're just going to go through all the basic exam-related ECGs and what common questions which can be asked, showing you those ECGs. So I have picked up some 7-8 ECGs which are very commonly asked in exams. So they'll give you one line of a brief history of the patient, that, this was the presenting complaint and all those things. And then they will show you the ECG. So this is my first case. One second. Yeah. So a 37-year-old male has been admitted to the emergency department with 12 hours of history of central crushing chest pain. He was rushed to the cath lab by the cardiologist, who referred him to the ICU 12 hours later due to hypotension and confusion. So this was the ECG. So you'll be given 2 minutes to read this ECG. So ideally, you should read every ECG with rate, rhythm, axis, and then intervals, and then go to the abnormalities and then give the diagnosis. These are the essential 5 steps in reading the ECG. So while reading this ECG, you can start with the general thing, like what rhythm is it? Is it sinus rhythm or not? What rate it is? I'm sure all of you know how to count the rate. And then what axis is it? If there is any axis deviation or not. And after that, just tell if there's any other abnormalities which you see. Count the see the intervals. What is a PR interval? What is a QT interval? What is a QRS? Go for that, and then you state the abnormalities. Like in this ECG, you can see that there is ST elevation in 2-3 AVF, the inferior leads. So and there is reciprocal ST depression in the lateral leads, 1 AVL and V6. And also along with that, you have again a piece of the case which was telling you that the patient presented to you with hypotension and confusion. So with inferior infarction, immediately your mind should, try to see, is there any signs of RV infarction? So that is very, very important, because inferior MI is complicated by RV MI in around 35 to 40% of cases. So look for the signs for that also. So what are the signs of RV infarction which you saw in the ECG? There was ST elevation in lead 3 more than lead 2, and ST elevation V1 and V2. So diagnostic criteria, they can ask you, how do you say this is inferior wall MI? What suggests that, it is right ventricular infarction? So you can tell some of these. I'm not going to go into very much of detail. The reason I listed all this so that you can read through it and you can answer it in this way. ST elevation in V1, ST elevation V1, and ST depression in V2, which is highly specific of RV infarction. And the diagnosis is confirmed by the presence of ST elevation in V3R to V6R. And V1 is the only standard ECG lead that looks directly into the RV. So this is the diagnostic criteria of inferior wall MI with RV MI. So what is the clinical significance? Why are we so concerned about RV-MI? They'll ask, okay, the patient is presenting to you with hypotension and confusion and dizziness. That itself is alarming enough for you to tell that, RV-MI can actually complicate around 40% of inferior MI cases. And these patients are very preload sensitive and can develop severe hypotension because you give them nitrates without knowing that it is RV-MI associated with inferior MI or other preload reducing agents. And this hypotension and RV infarction should be treated with fluid loading, and nitrates are contraindicated. So this is the significance. So this is a small ECG, which is a very important ECG. MI ECG can be asked to you any day, and definitely there'll be one exam ECG with MI, and they can ask you some related questions to it. So just go through what you have already gone through in the theory, just revise that quickly. So quickly going through the ECG anatomy, go through this inferior MI, posterior MI, and combinations of all this. So 2-3 AVF inferior MI, then inferior and RV MI. What do you see here? 2-3 AVF and V1 and V4R. I'm not going to go through this in too much of details. You'll have the slide to go through this. So knowing what are the ECG abnormalities, I picked up this from Life in a Fast Lane, which is a very, very, very good source for ECG reading for exams. So you can go through that. This I have picked up from our famous PAC module, and it is telling you which artery is involved. You should know all this. This is basics of your ECG table viva. They will very well ask you how to correlate the RWMA, which you see on the echocardiography, with the ECG leads finding with which artery is involved. So all that has to be correlated in your mind, and you have to answer in that way. So 2-3 AVF. Inferior and the artery related to it. Please go through the slide also for answering your exam related question with all the MI ECGs. So this is a brief thing for your first case, like an MI case if they give you an ECG. The second ECG, very famous, heart blocks ECG. So first is the MI ECG, which will be there. The second will be a heart block. So type 1, type 2, type 3, anything can be there. So I'm sure you guys know what this is. This is Mobitz type 2 heart block. The second degree heart block in which your intermittently non-conducted P waves are there without progressive prolongation of PR interval. So they can very well ask you about what are the causes of Mobitz type 2 heart block. So we all know that, ischemic causes are there, then you have your surgical causes are there, and then inflammatory conditions, autoimmune conditions, some drug related causes, some electrolyte imbalance related causes. So just go through the slide in which they'll ask you about causes of heart block. And then they can ask you what is the clinical significance of Mobitz type 2 heart block. Is it as bad as type 3, or is it is it as benign as type 1? So it is much more likely than type 1 to be associated with hemodynamic compromise and severe bradycardia and progression to third degree heart block. Onset of hemodynamic instability can be sudden and unexpected, causing syncope and sudden cardiac death. And the risk of E-systole is around 35%, which is quite high. And type 2 mandates immediate admission for cardiac monitoring, backup and temporary pacing, and ultimately inserting a permanent pacemaker. So this is the clinical significance of this heart block. So for a quick revision, I've added this slide so that you know about all the heart blocks. Please don't make a mistake in an ST elevation and a heart block ECG, because those are considered our basic ECGs, which we deal on a day-to-day basis in our clinical practice also. And these are very famous exam ECGs. So first degree heart block can be kept. You know that PR interval is prolonged more than 200 milliseconds, and because the conduction through the AV node is slowed down. Then the second degree heart block, which is also called the Mobitz type 1, the Venki back, where the PR interval is prolonged till over several beats till you miss a beat. And the second degree heart block, which the ECG I showed, the type 2 heart block, in which the PR interval is not prolonged progressively, but a beat is missed every beats with a normal PR interval. Correct. And the third degree heart block, which is a complete heart block, in which there is no relationship between the PR and QRS. And what are the causes of the AV block also? This is a beautiful slide which I have taken from Deranged Physiology. Again, a very, very, very good website to read through ECGs. So Life in a Fast Lane, Deranged Physiology. If you go through the ECGs, you're done. You're prepared for the exam. So these are the causes of the AV block, which are listed there. So you can consider drugs. You can consider other causes like, as I said, surgery or ischemic causes, which can cause these heart blocks. So this is also another important ECG for exam, which you should know about. Let's go to the third one. Sorry, my mouse is a bit stuck. Yeah. So this is again a small clinical vignette in which we are telling you a little bit about the history. not to confuse you, of course, to help you with diagnosing the ECG. There's a 51-year-old lady who is presenting to you with chronic vomiting, and she has history of rheumatoid arthritis and paroxysmal AF. Her medications, again, medications are giving you a clue that, so she is on sotalol and she's on rivaroxaban. So what do you see on the ECG? So I'm sure you will go stepwise, you will go through the rate, you will go through the rhythm, you will go through the axis, and then you will calculate the intervals, and then you will list the abnormalities. So this is how you have to approach each and every ECG in the exam. So again, I have written it for you. So the rate, you calculate the rhythm, you see if it is regular or irregular, if it's sinus or not, the axis, if it's normal or not, and the interval. So when you go to calculate the intervals, you'll see in this ECG, the QT interval is very prolonged. You know what are the normal QT intervals. Please know what is the normal QT intervals for males, what is the normal QT intervals for female, what is QT interval corrected. This is all our basics. We should be very clear with this. And any additional findings if you see in the ECG. So please list those also. Like ST depressions, you saw the depression you saw in 2-3 AVF, and prominent U waves you saw in V3 to V5. So these are the things. So what could be the cause of the QT prolongation? So you should know what are the causes of QT prolongation. There are multiple drugs which you use in ICU, which are culprits for QT prolongation in ICU. So there are a lot of antiarrhythmics which cause QT prolongation. There are a lot of electrolyte disturbances which can cause QT prolongation. There are a lot of antipsychotic drugs which we use for delirium in ICU, which can add on to it. So it's basically a synergistic effect of all these drugs and electrolyte disturbances, which can cause this as a very common finding, which is found in your ECG. So this is a very commonly asked exam question. I'll tell you in the next slide why. So marked QT prolongation leading to hypokalemia, hypomagnesemia. Now potential source here also could be because of the drug sotalol the patient was on. Now what happened after some time, the patient became unresponsive, and this is the ECG which you saw. This is again a very commonly asked ECG in the exam, especially after QT prolongation, if you didn't pay attention to the QTC or the QT interval, and later patient deteriorated and you saw this on the ECG. So what is this? This is also very commonly asked. This is your R on T phenomenon and degeneration into polymorphic VT. So polymorphic VT is another very commonly asked ECG question. And they can ask you, what will you do next? And you all know the treatment. You have to give magnesium. And what will you do? What bloods will you order? You will order an ABG. You will see metabolic alkalosis. If you do electrolytes, you will see all sorts of electrolyte disturbances like hypokalemia, hypomagnesemia, which can be contributing to this kind of polymorphic VT. And then you admitted this patient to critical care to closely monitor the patient's electrolytes, find the offending drugs, stop the offending drugs. Okay. And treat accordingly. So this is basically another common ECG which you can ask, you can be asked in exam, like QT prolongation and then polymorphic VT. Now this is again a very common ECG to be asked in exams, and every time I don't think there is any exam in which this ECG won't be asked. We all know what this is. So this is AF. So what are the ECG features of atrial fibrillation? Why would you say it's ECG of atrial fibrillation? So you can list some, like there's OP wave, there is irregular rhythm, there is no isoelectric baseline, there is variable ventricular rate, the QRS is less than 120, or you can sometimes see fibrillatory waves which are fine or coarse depending upon the amplitude, right? So this is your usual ECG findings in AF. Then they can ask you what are the causes of AF. We all know what are the causes of AF. I'm not going to go through this slide. This is just for your revision. You should know what are the causes of AF, and what is the classification of AF. This is related to this. They can ask you further questions. So what is, if it's a recurrent AF, is it a paroxysmal AF, is it a persistent AF? They can ask you all sorts of questions regarding AF. When do you anticoagulate in AF? What are the scoring system? What is CHAT2 score? What is Hasbled score? So the viva can go in that direction also. And as I said, for table viva, you have to be alert. You are post-lunch, you are tired, your adrenaline levels are going down. That doesn't mean that your alertness goes down. So be alert, answer the questions quickly, and it will be very, very scoring. You can score full marks in ECG. Okay, you can really score full marks in ECG. Another ECG which is commonly asked again, 86-year-old male patient is presenting to the GP with worsening renal failure. He has a history of AF and bradycardia for which a permanent pacemaker was inserted. His medications include metoprolol. Now this you can see an ECG. What is the problem with the ECG? Again, systematic approach is very important. As I said, rate, rhythm, intervals, and axis you have to tell. So describe and interpret this ECG. You have to tell the rate. What as you can see, the mean ventricular rate is only 24. The rhythm is irregular. There is no visible P waves. There is no evidence of capture. The history tells you that the patient has a pacemaker. So you have to say if the capture is there or not. Then you talk about the axis. So axis is normal axis. Then you talk about the interval. And then you can see if there is any additional findings or not. And after that, how do you interpret it? You have to say that, okay, the pacemaker is showing failure to capture, right? So causes of pacemaker failure, they can ask you. So usually it can be a single generator problem, like probably end of life or battery failure or any programming issue with the pacemaker, or over or under sensing. We all, get to see these in our daily clinical practice. And then connection between the unit and patient, there could be some problem with the lead, like migration of the lead, fibrosis of the lead, malposition of the lead, or fracture of the lead. Or there could be patient related factors, like whatever was the disease was progressing, so now the pacemaker is not good enough for the patient. So ischemia or any underlying electrolyte acid based disturbances or drug toxicity. So all these can be asked in a pacemaker related question, that what are the common causes of pacemaker failure which you encounter in a daily practice. So very clinical question in your table vivas will be asked, so which you guys will be doing on a daily basis. So you should be able to answer those questions. Again, another ECG, very common ECG asked, and very common problem which is encountered in the this thing. So we went through MI, we went through AF, we went through pacemaker, we went through the type of heart block. So these are the 5 top ECGs of the exam. Next and the last one which I'll tell you is the electrolyte ECG. So examiners love this for some reason. Hyperkalemia, hypokalemia, hypocalcemia, all these electrolyte related ECGs are their favorites. So you can be asked some kind of ECG like this, and describe this ECG. So you see there's severe bradycardia, there is broad QRS complexes, and there is symmetrical tenting of the T waves, which is a very important sign from V2 to V5. So there is a combination of bradycardia, flattening and loss of T waves, and broadening of QRS and T wave abnormalities. So you can be asked a differential of all these things. So differential of all these things, you can tell there's a severe hyperkalemia, and the background of patient also is a potassium is 8 and patient is anuric renal failure, end stage renal disease. So all these ECG findings of hyperkalemia is very important. They can tell you what are the ECG findings of hyperkalemia, how do you manage hyperkalemia. You all know all this, right? So you can tell about calcium, you can tell about insulin dextrose drip, you can tell about monitoring and everything. What else you know about management of hyperkalemia? Just tell all those things. So the viva will be leading in that direction. So again, another electrolyte related ECG and another peculiar finding in ECG, which you can be asked, not very peculiar, you can actually see it quite common these days. So a 30-year-old patient presenting with generalized weakness, and this is your ECG. So again, go in a systematic manner. Never forget to go in a systematic manner unless they're like, hurry up, give me the answer quickly, like that. If they're not telling, just go in a systematic manner, which I'm sure they'll not tell you. So go through rate, go through rhythm, go through axis, go through intervals. So, and then, tell about the additional findings and the abnormalities which you see. So in this, you see that, there is widespread ST abnormalities. There is biphasic appearance of the ST segment, and there's a negative initial deflection of the ST segment, that is ST depression or T wave inversion, followed by terminal positive deflection. This is very, a typical kind of ECG findings which you see, which is called the U wave, and all of them can merge to each other, and it will be difficult to tell in the end that which wave is what. And there is gross prolongation of the QU interval also, or QT interval. So diagnosis of the combination of all these findings, that is ST depression with T wave inversion and prominent U waves in the long QU interval, is usually suggestive of severe hypokalemia. And the patient presented to you with generalized weakness. So there's a small clue. They can give you more clues also, which will take you towards hypokalemia diagnosis. So ECG findings in hypokalemia will be like, ventricular tachycardia. Sometimes patient might go into torsades also. Then the viva can go to torsades, how to manage torsades and all that. Then PR prolongation will be there, P wave width will be increased, there'll be U waves, which are not unique for hypokalemia. That is a very important question. They ask, do you see U waves only in hypokalemia? So no, obviously you can see it in other things also, like bradycardia, it could be a normal variant also, or left ventricular hypertrophy also. So these cases also you see U waves, and then there is T wave inversions, there could be ectopics. So a lot of findings of hypokalemia, with some are specific, some are non-specific. So, this is how you answer your questions So this is where I end my ECG this thing. So we covered, all the ST segment elevation is STEMI ECGs. That will be one question that will be definitely there. There will be an AF or VTAC ECG. There will be a polymorphic VT ECG, which we covered. There will be electrolyte imbalance related ECGs. There will be heart block related ECGs. So these are the common ECGs which you will be asked. And ECG is very, very scoring. So don't worry. I'm sure you'll be doing really well in ECG section. Thank you. Any doubts we can answer?
We would be answering those queries at the end, just not
Yeah.
to go disrupt the flow. So because we have 3 more sessions to go, so we would be answering. And Dr. Mona Lisa, I would request you to go through the chat box and take the questions and answer in
Sure.
our group, so that
Okay.
would be helpful. Okay.
Okay.
Thank
Thank
you.
you.
Thank you, Dr. Mona Lisa, for discussing it so elaborately and very descriptively for our students. Now moving ahead, Dr. Santanu or Dr. Vishwa, who would be starting? Dr. Santanu?
Yeah, I'm there. If you suggest, I can go ahead.
Yeah, please.
So, good evening, everyone. Good evening, Dr. Sheila, Dr. Ray, good evening, Dr. Sahu, as well as Dr. Sanan. Without any further delay, let's first share my screen. And today, my part will be to discuss some of the important snapshots like your graphics or some of the clinical lab parameters, like those data that might come in your exams, and those which are the common ones. I've tried to pick those up and we'll try to discuss few important areas regarding this. So coming in the first one, the ABG, which has been pretty common in any of your practical exam. So this is one example I have taken. And as you can see, there are multiple abnormalities being present in the ABG, right from the pH to the bicarb to the base excess to the electrolytes, as well as the lactate. There are some multiple abnormalities being present in the ABG. So if you want to roughly find out or the point out what are the abnormalities being present, you can see there is a metabolic acidosis is there. There is some incomplete respiratory compensation has been there going by the Winter's formula. You can see the PCO2 should be around 25 millimeter of mercury, whereas in the ABG you can see the PCO2 being around 35 millimeter of mercury. Then the anion gap is also on the lower side. It is coming around 6 millimole per liter. And there was some, along with those, there are some electrolyte imbalance also. So once you try to analyze an ABG, the step should be very simple. And as we all are doing in our day-to-day practice, you can see first of all, you need to see whether this ABG is authentic or not. You need to compare the hydrogen ion status of this ABG as per the standard formula. And then you need to find out the pH, whether there is any acidemia, alkalemia being present. Then you need to find out the cause of this acidosis or the alkalemia which is there, whether it is respiratory or metabolic. Then you can go for whether the adequate compensation has been there or not. If it's a metabolic primary, then what is the anion gap status? If it's a high anion gap status, then what is the gap value is there? So those things needs to be checked in a stepwise manner. And if you go through this ABG in this stepwise manner, you can find first of all, you are having a triple acid base imbalance. There is a non-anion gap metabolic acidosis. There is a high anion gap metabolic acidosis, as well as there is some respiratory acidosis impaired compensation. Now coming to the cause, although the history has not been given, but if you want to think about the causes of normal anion gap metabolic acidosis, the causes can be additional crisis. There can be simple fluoride excess might be there. It can be drug induced. It can be bicarbonate loss from the GI tract. Those all can cause some sort of non-anion gap metabolic acidosis to happen. Along with those, you are having some electrolyte imbalance and hyperlactatemia also. Now, coming to the next graphics, which can be there in your exam, it's the TIG, as many of you are doing it on your day-to-day ICU practice. I have kept a couple of TIG snapshots there in our presentation. And as you can see in the first one, there are some abnormality like the R time, the reaction time is little on the lower side. You can see the clot lysis after 30 minutes is on the lower side. And along with you are having a hyperacute angle and the high maximum amplitude. So the diagnosis can be made as a hypercoagulable state. Simultaneously, I've kept one more take snapshot, and you can see here just in the contrary to the previous one, the clot lysis time after 30 minutes of the maximum amplitude is on the higher side. It is coming around 19.4. So here you can safely diagnose it as a DIC being present as the underlying condition. So some few comments about the thromboelastogram in general. As you know, in a typical graph, you are having starting with the coagulation part up to the fibrinolytic part. Starting with the coagulation part, you are having the reaction time to start with. It is basically the time till initiation of the fibrin clot formation. And the normal value should be between 5 to 10 minutes. And in case of decrease in the coagulation factors, you will have a raised reaction time. In K value as well as the alpha angle, these are all that being affected by the decrease in the fibrinogen level. So if you are having a hyperfibrinogenemia, you can get a raised K value or a decreased alpha angle. Coming to the maximum amplitude, you can find if there is any low platelet count or dysfunctional platelets being there, the maximum amplitude will go down. In the clot lysis after 30 minutes of the maximum amplitude, you can see the increased clot background will be there if there is, and that will cause the rise in the clot lysis after 30 minutes. So that's how we need to analyze the different take diagrams that might very easily be there in your exam. Now coming to a third scenario, you'll get some values here. Lab values. This is one type of data interpretation is very commonly being there. It's a female patient coming with some central nervous system issues, and the CSF analysis has been done on this patient, and you can see the CSF report here. You can see the total counts are being on the higher side, the proteins are little bit on the higher side, and you will be asked what are the differential diagnosis, whether you need to go for any further investigations or not. Any therapy you would like to start with. Those kind of clinical questions also might come from this this type of data which is being presented to you very commonly in your practical exam. So just a brief look back to the normal values. You can see the protein should be around 0.8 to 0.45. This is the glucose, the gram stains, the glucose CSF, the glucose ratio between the CSF and the serum is also very important. So that you need to also look for, and you need to find out whether there are other abnormal cells are there or not, and what are those type of those cells. So coming with those, if you go back to the CSF picture, we got the disease can be the viral meningitis, can be the chronic meningitis being TB or syphilis being the underlying cause, it can be an extension of the cerebral lymphoma, and it might happen because of some partially treated bacterial meningitis also. Now, what are the additional investigations you need to go for? You need to analyze whether the underlying tubercular analysis should be completed. You need to go for some specific CSF PCR studies to rule out other different viruses which can happen as the positive factor. You need to look for the cryptolocal antigen, and ultimately you need to go for an MRI brain also. If all those analyses are inconclusive, you need to go for an MRI brain also. Regarding the therapy, you can safely start with acyclovir provided the renal function is not that impaired and the clinical indication is there. Now coming to another data or another condition where starting with a brief history, like a male patient who is being chronic alcoholic and is coming with some breathing difficulty and abdominal pain, and you can see the X-ray, you can see there is a significant right-sided pleural effusion being present. Now, coming to the pleural tapping has been done, and those pleural tapping reports is being explained or shown here. You can see, just focus on particular values, like if you can remember the Light's criteria to differentiate between the transudate and the exudate, just focus on those parameters which I have tried to keep here. Just see the LDH value, see the protein value, and so I need to compare between the pleural fluid protein and the serum protein, as well as pleural fluid amylase, LDH and the serum LDH. So you can see the parameters here, and you will be asked what is the type of abnormality you find here. And usually, it's, as going by the standard criteria, you can find it's a transudative type of pleural fluid, and the underlying cause. Hello. There is some disturbance in the background.
Yeah, requesting everybody to please mute their mic. Yeah.
Thank you.
Yeah.
So going by the clinical history, the cause of this transudative fluid can be cirrhosis of liver also. That's a possibility. You cannot diagnose just by these parameters only. So just as a recapitulation of the Light's criteria, you can tell it the pleural fluid safely you term it as an exudative one if the pleural fluid protein level to serum protein level ratio is more than 0.5, or the LDH level between the pleural fluid and the serum level is more than 0.6. And these are the different causes of the transudative and exudative pleural effusions. Now coming to the next case scenario, or next, I would say the details. This is a middle-aged female being shifted to your ICU after an emergency laparotomy being done, probably for some intra-abdominal sepsis, and you've got an history that patient has gone some significant blood loss has happened intraoperatively, and this patient got shifted to your ICU, and the lab parameters, the initial lab parameters, what you can see are those. I have not kept the abnormal ones as red. I kept everything in the black color only. There you can find there is some significant drop in hemoglobin. Additionally, one more thing I would like to touch upon, the white cell count is also on the lower side. You can suspecting an intra-abdominal sepsis. So this is one of the manifestation of the underlying severe septic shock might be there. And along with those, you are getting all those coagulation parameters being deranged, fibrinogen, the APTT values, the INR values, as well as the platelets, all are on the abnormal side. So the questions can come like, what are the possible causes of this coagulation abnormalities and how to correct those? Pretty straightforward questions, but so there you need to keep your cool and think the logical ones going by the history. It can be inadequate replacement of the blood and components. So there will be some hemodilution, as well as the commonest one, the patient is going into a de-ice state. So these are the common two causes which can happen in this patient. And regarding that management, definitely you need to take care of the lethal triad. So you need to avoid all sorts of hypothermia, and you need to avoid all sorts of acidosis. Also, the acidosis needs to be corrected, and simultaneously you need to replace the platelets, the FFPs, the cryos, as you got the fibrinogen value also being on the lower side. You might consider some tranexamic acid in the initial phase, and definitely ongoing surgical hemorrhage also needs to be excluded. So from this lab parameters, they will definitely go into some clinical management and clinical scenarios challenges definitely in your exam. This is the normal coagulation pathway, just kept as a theoretical purpose. Now coming to this waveform, this is the, as you know, this is a transcranial Doppler waveform, and the history has been given in a patient with subarachnoid hemorrhage. What is the abnormality they might ask for? You can see along with this waveform, you just go through these parameters also on the right side. And from there, if you see the mean flow velocity and all, you can safely diagnose it as a cerebral vasospasm being happening. So transcranial Doppler, as you all know, basically it's a bedside low pulse monitoring of the cerebral hemodynamics. So you can assess the cerebral hemodynamic status very well with this transcranial Doppler. You need to go through some of the parameters of this modality. You need some training, and it will be very easy to assess to some extent the brain pathology underlying in your patient. So regarding the parameters which you need to look for, one being the pulsatility index, which is very important to diagnose a raised ICP. So what is pulsatility index? It's a difference between the systolic flow velocity and the diastolic flow velocity divided by the mean flow velocity. The value should be normally less than 1.4. Regarding the mean flow velocity, the next parameter which needs to be looked for, the normal range is around 60 to 80, and in our case, you can remember the value was something around 125. So as you can see on the right side of this screen, the cerebral vasospasm can be safely diagnosed with mean flow velocity. And once it is going beyond 120, you can diagnose it as a moderate cerebral vasospasm being developing. And with a higher value beyond 200, you can diagnose it as a severe cerebral vasospasm being developing. There are other parameters also like diastolic flow velocity, limb-wave ratio, mean flow index. Those are also needs to be taken care of in a typical transcranial Doppler waveform analysis. So regarding the two common scenarios like the raised ICP and the cerebral vasospasm, how to suspect from a waveform. So once you are suspecting some high ICP in a patient or in your scenario, then just try to look for the pulsatility index and the diastolic flow velocity. So whether those parameters are within diastolic flow velocity less than 20 or the pulsatility index more than 1.4, definitely you can think of some invasive ICP monitoring would be required. Probably the patient is having a significant high intracranial pressure. And on the other hand, regarding vasospasm, as I mentioned, the mean flow velocity should be less than 120. If it is going beyond that, definitely you need to think of some cerebral vasospasm being happening. Now coming to the last and graphics or last snapshots which I have kept. The only one ventilator graphics I have kept, as you can diagnose from here, you will be asked that what is the diagnosis, what is the abnormality you can see in this waveform, and what should be your management plan. So just going by this particular example, you can safely diagnose it as the auto peak being generated, and you will be asked what are the management principles. You need to mention that the expiratory time needs to be increased, so you need to reduce the respiratory rate, you need to increase the inspiratory flow, you need to go down with the IE ratio, and ultimately you need to target the ventilation according to that. So regarding these ventilator graphics, I didn't kept multiple graphical examples. Rather, instead, I could not resist myself by sharing this particular article that has come up in 2022 July only. Many of you probably has gone through this one. This is from the ASA headquarters. The American Society of Anesthesiology team has given this article. This is a very this ventilator waveform analysis is pretty confusing for many of us from the beginning. So if you go for a stepwise approach, then definitely it will be useful to assess the pulmonology, pathophysiology, which is there underlying. So what they have suggested, they have given some particular steps. Like you need to, in the step one, you need to assess the expiratory flow waveform. Once you are getting a ventilatory waveform in the bedside or in the exam, first try to assess the expiratory flow waveform to generate a pathophysiologic hypothesis. So what do you see in the expiratory flow waveform? You can see whether there is any autopy being generated, whether there is any active exhalation is there or not, whether there is any expiratory flow limitation is there or not. All those things, many other things you can assess from the expiratory flow waveform. Next step, they are suggesting to assess the inspiratory flow waveform to corroborate the pathophysiologic diagnosis we have made from the step one. So in inspiratory flow, just going by the mode of ventilation, you can see whether it's a square or the descending flow waveform in a volume control ventilation, or whether it's a pressure control ventilation, you are getting a proper decelerating flow pattern waveform is there or not. Then in the third step, they are suggesting to assess the inspiratory pressure curves to confirm the pathophysiologic diagnosis. So there you can assess the plateau pressure, you can find out the driving pressure, as well as you go into the particular modes, individual modes also. Next step, they are suggesting to identify the triggering source. So there you are supposed to basically find out whether there is any proper failure of triggering happening or not, or on the contrary, there is some auto triggering is happening or not. Those things that needs to be looked for in step 4. And finally, in the step 5, they are suggesting to identify the time between the inspiration and the expiration. Basically, they are trying to focus on the cycling time, whether there is any delayed cycling or in the premature cycling is being happening. So they have given some typical examples, like in the first step, as I was mentioning, we need to look for the expiratory flow waveform. Here the green bold lines are being mentioned as the expiratory flow waveforms, and you can see going from the normal one in the high resistance pattern, you can see the reduced peak expiratory flow is going down, and there is a prolonged expiratory time happening. On the other hand, if it's a low compliance state, you can see the peak expiratory flow is going higher. See, in expiratory phase of the respiration, if you're checking on the ventilator graphics, it will be always below the line, and the inspiratory phase will be above the line. So in expiratory phase, you can see the peak flow is going pretty high, and on the other hand, you are having a short expiratory time. That shows the compliance on the lower side. Auto peak already being explained. If the patient is having some expiratory effort, then the normal scalloping is gone, and then you will have a concave pattern in the expiratory flow. You can have some tracheal secretion oscillations on the expiratory flow that will signify some tracheal secretions being there. And if patient is having some inspiratory effort, that also will be there in the expiratory graph as an upward indiscriminate deflections. Now coming to the inspiratory flow waveform, it's a square waveform in the volume control. It can be the descending waveform in the volume control, and on the other end, on the pressure control mode, the standard being the decelerating flow. In case of any high resistance, you can find the peak inspiratory flow is going on the lower side. And on the other hand, in case of low compliance, similarly, the peak inspiratory flow will go up rapidly, but the short inspiratory time constant will go down. Now coming to the third waveform, the pressure waveform for volume control ventilation with the square waveform pattern, you can see that this is a very classic ones. The first one being the normal peak airway pressure, the plateau pressure, and the peak plateau gap is all normal in the first one. But in case of high resistance, you can find the peak plateau gap goes up. On the other hand, in case of low compliance, you can find the peak plateau gap goes down. And if you are having the both, like the high resistance as well as the low compliance, then definitely you will find the peak plateau gap will go up along with the high peak airway pressure and high plateau pressures. And similarly, one more important thing in this waveform to find out is the stress index. So here, normally you are having a stress index of between 0.95 to 1.05. So linear rise is there, but in case of proper recruitment, there will be some parabolic rise. The stress index will go below 0.95. And on the other hand, if you're going towards the end of your recruitment and there is over distension happening, then definitely the stress index will be having a scalloping pattern. The value will go beyond 1.05. And lastly, this pressure waveform in a descending waveform, you can find the resistance, particularly in the volume control mode. You can find if there is increased resistance, the pressure goes high in the initial phase, and the end inspiration, the pressure goes down. And in low compliance, the opposite happens. The pressure goes up in the end inspiration phase. And in case of the cardiac oscillation, that is also being very prominent here, and in the inspiratory effort, the normal curvature goes down, and in case of reversal of trigger, you will get an additional triggering in the inspiratory phase in volume control with the descending flow. So with this, I'd like to conclude this part of this session, and we'll be happy to get questions on this at the end.
I know it's a very difficult task to finish 3 important parts in 15 to 20 minutes. Dr. Santanu, great job. And we would be moving ahead with the next one that is very important, again, radiology. And for that, we have Dr. Biswa Vikas Mohanty from Bhubaneswar. Dr. Biswa, please. Dr. Biswa, are you there?
Yeah, yeah. Very good afternoon. Good evening.
Good evening, Dr. Biswa.
Yeah.
You can straightforward start. Yeah. Thank you.
Okay. So very good evening to all of you. So after a very few 2 sessions of ECG and graphics, we'll go to the next most important one of the mark fetching, what I can say. This is radiology, because here you have to only diagnose, that is for diagnosis, and this is mark fetching. So I will go a little bit quick because I have to cover a lot of things. So I'll give a clinical clue and show the radiological feature. Then the next question, what the examiner will ask, only I will highlight. Okay. So what I will highlight in this topic is chest X-ray, to some extent abdominal X-ray, ultrasound, which is very important, to some extent echocardiography, and CT brain, which includes CT of brain, chest, and abdomen, which is most relevant from the exam point of view. I will highlight, and some of the MRI brain, and if possible, I'll go from the Doppler scan, especially for the DVT. So here in the chest X-ray, which is very important from DNB point of view, here the common questions what the every exam they will ask is the ARDS, consolidations, pneumothorax, pleural effusion, hydropneumothorax. Sometimes they may ask for foreign body, especially if the pediatrics one, and hiatus hernia, and most important is the abnormal position of the line. This is very important. Every other examiner will ask you about the abnormal position of the lines. So this is in general, this is very important. As Dr. Mona Lisa was highlighting regarding the ECG, here it is also very important how to read an exam of X-ray. This is systematic manner. Here you have to always mention what is the type of view, whether it is PA, AP, or lateral, whether it is well centered or not. We have to tell about the exposure, whether it is overexposed or underexposed, and which phase of the respiration, whether it is inspiratory view or respiratory view. These we have to mention in every chest X-ray. Otherwise, if the examiner is not hurry about, just tell me the diagnosis like that. Okay. So with this, we'll go straight forward to the clinical scenario. So here is a 48-year male So post-whipple surgery, 2 hours later, landed in the ICU, and we found that patient's saturation is coming down. This is the X-ray. So this is very straightforward. You can see the endotracheal tube is in the right endobronchial position. So you have to mention that this is right endobrachial intubation, and along with also you have to mention about the left lung collapse. So for your understanding, I have mentioned here the tip should be 5 centimeter above the carina. The maximum allowed distance is up to 2 centimeter above the carina. So here they may ask you again like side questions, how will you manage this patient? What is the treatment, like that? So this is the side questions they may ask you. So here another patient is like right side hydropneumothorax. Here is the ICD we have inserted. So you have to comment. They may ask you what is the defect here in the X-ray after you have inserted the ICD. Here you have to see that this ICD is not functioning properly because it is inside thorax but not in the pleural place. So they may ask you, so what will be your next management? Then you can say that we have to reposition the ICD and you have to repeat the chest X-ray, like that. The third question is, it is an 88-year-old man who is being some multi-system failure, maybe due to septic shock. So you have inserted an NG tube, which is in place. So after that, we have not confirmed about the position of the NG tube. So you have advised on chest X-ray. The chest X-ray is shown in the figure. So what is the abnormality? This is a very common question as I have highlighted. So here the NG tube is coiled and is placed in the left bronchi. So this is straightforward. We have to diagnose only. So another question is, he's a 70-year-old patient with the advanced glioblastoma multiforme. Now he's admitted with shortness of breath. So you have to comment on the invasive line. So here, so this is very unusual. So you have to comment one line is here. So so you have to comment on the line because the patient is endotracheal intubation, the tube is there. So you have to comment on the line. This line, you can say that this is the VP shunt catheter in situ. This is very important because sometimes we may miss it or with the ECG cable, everything, but this is something because this patient of glioblastoma multiforme, mostly he has been done the VP shunt before. That is, so you have to mention this is VP shunt in situ. So this is a patient of cardiogenic shock after drug overdose. He's intubated. A chest X-ray we have done in the ICU. So we have to comment on the X-ray. So here you can see this is the IBP tip is too high. So this is malposition of IBP. Another thing is you have to mention of the transcutaneous pressure. So, and we have to mention that endotracheal tube positions is improper. So we have to mention 4 things. If you are not mentioning all these things, then you are just losing your mark. So you have to just know where is the IBP catheter tip should be. They may ask you where is the exact position of the IBP catheter tip. So you have to mention that within proximal descending thoracic aorta, distal to the origin of the main branches of the aortic arch, and just distal to the origin of the left subclavian artery. So this is very favorite questions. Most of the examiner will ask if you get a IBP catheter. So another question is a 16-year-old male who has having 40% burn. So he's developed respiratory distress on the second day in the ICU. You have comment on the X-ray. This is very straightforward. So you have to mention like that. This is a bilateral multifocal air space of ossifications, mainly perihilar and in the lower zone. So most common diagnosis is ARDS. So here is a 79-year-old male who is 40 hours history of cough with under low-grade fever. Now is present to be the right-sided pleuritic chest pain. So you have to comment on the chest X-ray. Here we can mention that this is this is the airspace shadowing and air bronchogram in the right upper lobe. So you have to tell the most common diagnosis. This is community acquired lobar pneumonia. So you have to mention that this is, maybe you can tell that lobar pneumonia, whether it is community acquired or not, we cannot mention. So you have to mention this is lobar pneumonia. So this is another 40-year-old in the severe respiratory distress and he is intubated on arrival. We have to mention on the X-ray. So here this is complete collapse of the left lung and there is no air bronchogram. So trachea deviated to the left right hand border is not visible, that is mediastinal shift. So they may ask you which procedure you want to do immediately to salvage the patients. So your answer will be bedside bronchoscopy, because their most common is the mucus plug. So now, so you have to know what is the difference between collapse and consolidations, because this is also very frequently asked questions. In the collapse, there will be volume loss and ipsilateral shift of the mediastinum, and there will be no air bronchogram. So whereas in consolidation, there is normal or increased volume, there is no shift, or if present, it is contralateral shift of the mediastinum. But the important thing is there will be air bronchogram. So another question is now. The next question is, so it is a 41-year male patient who is having a road traffic accident, who is complaining and chest pain, severe chest pain. So we have an advice on chest X-ray. Here it is left pneumothorax with mediastinal shift. So because you have to mention the mediastinal shift, because here you can see the trachea shift, shifted to the contralateral side. So this is, we have to mention this is a tensor pneumothorax. Pneumothorax is also very important questions, and they may ask you what is the management here. So here is a patient having severe abdominal pain, and we have and the abdomen is grossly distended. We have advised for the abdominal X-ray. So you have to comment on the abdominal X-ray. This we can tell that it is marked diffuse colonic dilatations. The most common diagnosis they may ask you is Ogilvie syndrome, and they may ask you what are the causes in especially in the critical care scenario. You have to mention like dyselectrolytemia, immobilization, OPERD, everything you have to mention. So now we'll go to the ultrasound. It is very important nowadays, because nowadays ultrasound, all the bedsides, X-ray, everything is replaced by the bedside ultrasound. Here, the most important things I have covered will be the pneumothorax, pleural effusion, pericardial tamponade, so pulmonary embolism, like RRB dilation, pulmonary edema, and IBC diameter and collapsibility. So here, one by one, I'll go. Here is a 47-year-old man with road traffic accident, injury to the chest wall. He's complaining of chest pain, and you wonder whether there is a pneumothorax, because you cannot wait for the X-ray to do and to comment on the pneumothorax. So you have gone for the bedside ultrasound. So here you can see, I will show the video. It is a very small video. If you are able to see here, you can see there is no loss of there is loss of long sliding. So long sliding, if it is absent, this is a very significant for the pneumothorax. Here you can see there is long sliding is present, whereas in the upper X-ray, the long sliding absent. So you have to be very much clear about pneumothorax, because they will ask you everything about pneumothorax on the ultrasound finding, because it's a very nowadays very favorite question for all the examiners. So here you can mention that abolish long sliding, stratosphere signing on airboard. The A line sign, that is 1B line, is enough for ruling out the diagnosis of the pneumothorax confidently where probe is applied. And the most important one is the long point. Here I mentioned the long point. So long point is basically the point, transition point between the mobile and immobile lungs, which is specific to pneumothorax. If it is present, then the long pneumothorax is 100% specific. So here in this I am able to show you what is long point. You can see here, this is you can see the long point sign in the M mode. So appear at the precise line where the seesaw sign switch to stratosphere or barcode sign. It is very specific to pneumothorax. Now it is a 50-year-old smoker with fever with 1 month history, shortness of breath for last 7 days, and now it's come to you with a left-sided chest pain in the last 4 days. So we have done for ultrasound. Here you can see this is a gross pleural effusion with underlying lungs collapse. So because you can see the hypoechoic region with underlying lung collapse. So this is very straightforward, but you have to mention. They may ask you what are the causes of unilateral pleural effusion, what is the management. So we have to answer. Now the next question is, so you are the bedside doctor in the night. So you want to insert a right internal jugular vein under the ultrasound guided. guided. Now you know that all the central line we are inserting on the ultrasound. So we have gone for a bedside ultrasound. Here we have to comment what is the ultrasound findings. So here you can see the internal jugular vein contains some heterogeneous and echogenic thrombus. That is so you can tell that it is right IJB thrombus, but you have to mention it is some heterogeneous and echogenic substances there. That most common is IJB thrombus. So then the next question is, so he's a 54-year-old male presented with collapse while moving the couch. The patient is an antibiotic for his pneumonia for the diagnosis. Now the patient is altered mental status in the emergency department. So we have gone for a chest bedside echo in the emergency. So you can see in this is a very small video, but you can see here. So the right side, this is a parasternal long axis view of the heart with large right heart and the septum going into the left ventricle. So these all things we have to mention because parasternal long axis view of the heart with a large right heart and the septum is deviated to the left. So your diagnosis will be massive pulmonary embolism. Then may ask you how to go ahead if the patient is hemodynamic unstable, what to do, if the patient is hemodynamic stable, what to do. So now this is another question. It is a patient which post-op CABG day 2 now develop cardiac arrest. We have given a CPR, but if the patient is revived. So now we have gone for the bedside 4-chamber view. So you have to comment the echo. Here you can mention that this is apical 4-chamber view. There is a massive pericardial effusion, maybe in patient in pericardial tamponade. Then they may ask you what is the next level of management. Then may you call the cardiologist, go for a pericardiocentesis. So this is a post-op day 1 patients in our ICU who is gone for surgery for the for abdominal surgery. Now the patient develops oliguria. You want to check the volume status. So this is we have gone for the bedside IBC diameter checking. So here you have to comment on the IBC. So this is you have to mention this longitudinal view of the IBC deep to the liver. Now the IBC is flat with complete collapse on inspiration and very little filling only seen during the arterial systole on expiration. That means IBC collapsible. Now they may ask you what is your next level of management. Then you may tell that depending on this IBC, I will go for volume resuscitation. So now this is an they may ask you this type of questions. So like traumatic brain injury patients intubated for low GCS, city brain with severe cerebral edema. Now the people is unequal with bradycardia. We cannot wait for the city brain. So bedside we have gone for the ocular ultrasound. So what is this? They may show you this ultrasound. So what is your diagnosis and what is your immediate management? So with this, you can tell that this is RAGE ICP, which is with your optic nerve field diameter more than 6 millimeter. So how to manage it? You can tell that RAGE ICP management like hyperventilation, bed and elevations, hypertonic saline or trip or mannitol depending on the like renal failure or hemodynamic stability. So now with this, we'll go to the CT thorax. It is also very important. Here we'll comment on mostly pulmonary embolism and aortic dissection. These are two common things they ask. They may ask you like aspergillosis, halocines. They may ask you consolidation. But I have here I have kept only two. So basically, this is a 54-year-old male. So presented with shortness of breath after long travel. So because the chest X-ray was normal, we have advised for a CT scan. So we have to comment on the CT scan. So we have to mention this is a like CT pulmonary angiography. So here, if you see this type of things, that means the patient has taken some contrast. So we have to mention this is a CT pulmonary angiography. Here it is showing bilateral proximal acute pulmonary embolism. So if it is segmental, also we have to tell that this is segmental pulmonary embolism. If it is proximal, you have to mention that proximal like main artery pulmonary embolism. Then they may ask you what is the management. Then you can mention that depending on the hemodynamical stability, whether to decide for thrombolysis or anticoagulant, we have to tell that. Now this is the next question. So it is a 70-year male, a chronic hypertensive. Now it's presented to your hospital with sudden onset chest pain. So your cardiologist has straightforward gone for the ECG and they clinically suspected something abnormal. So we have gone for a CT angiography. We can found, but we have to comment. So this is the you have to straightforward tell that this is a CT scan, where you can see this is a aortic dissection, because here we can see in the intimal flaps there is double lumen. So that means you can say that it is a case of aortic dissection. So you may get in cases of aortic dissection like intimal flap or dilation aorta, or an atypical variant they make like aortic intramural hematoma. But this is very classical if you are getting a double lumen. So this is very classical for aortic dissection. They may ask you what type of management will go, like blood pressure control, whether to go for alpha blocker or beta blocker. They may ask you all these things. You have to be prepared. So now this is a 56-year-old chronic alcoholic present to the severe abdominal pain. So in the abdomen, abdominal CT, if you get these type of cards, so mostly they may ask you acute pancreatitis, or they may ask you some intraperitoneal hemorrhage. So they may not ask you like atypical CT scan, because the ACT abdomen is really tough for diagnosis. So if you are getting this type of questions like severe abdominal pain, alcoholic, like amylase lipase is high, so we have to correlate this from the history that this is the case of acute pancreatitis. Here, this is a case of acute necrotizing pancreatitis. So the CT feature of acute necrotizing pancreatitis may be edematous pancreatitis or necrotizing pancreatitis. In the edematous pancreatitis, there will be only focal or diffuse parenchymal enlargement. There will be change in the density because of the edema. There is indistinct pancreas margin owing to inflammation. There may be surrounding retroperitoneal fat standing. But if it is like necrosis, you will find that there is lack of parenchymal enhancement. That is, so mostly the necrosis will be after, ideally should be 1 week after the symptoms onset. So there will be, if it is like that, in the history, you can able to distinguish whether it is necrotic pancreatitis or this edematous pancreatitis. So this is another CT abdomen. This is a patient present to you like tense abdomen and fecal vomiting, high lactate in the ABG. So like in this history also, they may history like that patient had a history of F, like that. So you're suspecting like bowel ischemia. So so in this type of CT, if you see this type of air is there, so you may like that. This is maybe bowel ischemia. So though it is difficult, but it is easy to diagnose because you can see large volume of portal venous gas. This is very classical for like bowel ischemia. You can see here in the portal venous phase, this is some air. This is very specific for the bowel ischemia. And there may be long length of non-enhancing small bowel with edematous intestinalis. So this is also very specific for the bowel ischemia. Though it is difficult, but from the clinical clue, you may tell that because in the abdominal CT, as I have highlighted, only 2 to 3 cases they will ask you like bowel ischemia, like acute pancreatitis, and the another one is the intraperitoneal hemorrhage. So here you can get it poorly enhancing or non-enhancing bowel wall, nematosis intestinalis, that is intramural gas, small bowel fecal sign, like that they will get it. So this is last CT for the abdomen. Here is the 56-year-old male, ischemic stroke, thrombolized in the within period. Now develops sudden onset of abdominal pain. What is your diagnosis? See, from the history only you can get suspect, because in the abdomen CT we are not so much confident. So here, if this, you can suspect that if it is thrombolized, there may be intraperitoneal hemorrhage. Here you can see this is the intraperitoneal hemorrhage. With this, there is some contrast extravasation. So you can mention that it is abdominal CT contrast shows large hematoma with contrast extravasation in the abdomen. So now we'll go to the neurology part. So here in the neurology also, everybody will ask like common things like ischemic stroke, ICH, EDH, SDH. In some cases like MRI, they will ask you encephalitis, praise, and if sometimes also they in the trauma cases, they may ask you cervical spine injury. So here, so they will give some case scenario like 77-year-old woman, sudden onset left side weakness with numbness. She was seen last for normal 4 hours before. So coming to the CT, it is a CT, what is your diagnosis or what is your management? This is very straightforward. So that's why you should able to distinguish between infarct and the hemorrhage. So this is very classical. You can see this is the infarct involving right MC-attenuated infarct. Also, you have to mention in the like midline shift. So see here the ventricle is a little bit compressed. That means there is some midline shift. So they may ask you the management, then you have to go for like antiplatelet statins, reperfusion therapy like intravascular thrombolysis, if no contraindications, you have to mention like that. So it is a 24-year patient, big road traffic accident, presented with loss of consciousness. This is a very typical city. Here you can comment, lot of things are there. Here you can see like EDS is there. Here SDH is there. Here is some subarachnoid hemorrhage is there. There is some like open skull fracture is there. This is a very classical city. They may give you like that only. So that's why in the next slide, I have told mention here how to distinguish between EDH and SDH. EDH like that only, you can see it is a convex separate opacity. So, but in the SDH, you can see this is a convex concave type of opacity. But in the SDH, we have to mention whether it is acute or chronic, because here like acute and chronic. So if it is more blackish like hypertension, it is chronic. If it is white, that is hypertension, it is more of acute. So we have to mention whether this acute or chronic, or this chronic or it's acute, we have to mention. So if they will come the management, because EDH is an emergency, you have to go for the immediate CT. So this is also classical CT like 54-year hypertensive, suddenly got prolapse, the CT scan, what is your management? Here you can see this is classical of large hematoma in the left thalamus with intraventricular extension. So we have to mention all things. This hemorrhage in the which is the classical area along with the intraventricular extension. So how to manage? They may ask you. So you have to tell that neurosurgery consultation, all this anti-edema measure, you have to mention. So this is a classic like 45-year female patient, sudden onset headache. So they may ask what is the diagnosis and immediate management. This is a classical subarachnoid hemorrhage. This is perimesencephalic. They may ask you what is the where the sylvian fissure. This is the typical locations you have to mention. So what is the management? So we have to immediately call the neurosurgery if there is surgical intervention. Like they may ask you what is the to prevent vasospasm. So we have to mention this drug. So this is some MRI, classical MRI I put here, so like 65-year male presented to with high blood pressure in the ER, and the patient is presented with confusion and cortical blindness. This is classical. So if so they may show you the MRI. So with this, you have to diagnose this case, how to management. So, so like hypertensive patients, confusion in the posterior, like occipital area, hypertension density. This is classical MRI of PRES. We have to mention this. This is flare MRI, hyperintense lesion, bilateral parietal occipital area. This is classical of PRES. So how to manage? This is aggressive correction of the blood pressure and supportive care. This is another classical MRI. They may ask you like 34-year female male patient present with fever, altered sensorium, and some weakness. So we have gone for a MRI. So CSF we have done. So suspecting like viral encephalitis. So we have gone for a MRI. This is very classical of like herpetic herpes encephalitis, because this is a T2 signal involving left temporal lobe and insular cortex. So this is typical of herpes encephalitis. You have to go for acyclovir. So if this type of MRI they will give, so if it is temporal lobe involvement, it's very classical of temporal lobe, like herpetic encephalitis. It's very common. So they will ask you this type of MRI in the exam only. So I think I have finished my topic. So whatever possible I have finished. So if anything is there, so we'll share in the in our group.
Thank you, Dr. Biswa. You have completed a very vast topic, and that to all the systems assimilated together. So hopefully the candidates will get a clue how to frame their answers in like short time. And you have to go through and make your own like the folder of all the important the radiologic images, and start practicing it for next 1 month or so. So with this, we come to end of like our the first three, and now the last one is pending, which is the most important. I will say, which we are not practicing in our day-to-day clinical practice. So that is why we have kept it to the last one, and for that we have the best person, that is Dr. K. Swarnadipak from Hyderabad. Dr. Swarnadipak, please.
Thank you, Tapas bhai. So as you rightly said, I think, so in fact, I think any person who has attempted an European exam, for example, that is an MRCP, maybe in any kind of European exam, no, in the Denmark or wherever it is, you know the communication section, the importance they attach to it. And in fact, the marking, when we actually go through the marking pattern, no, the highest failure rate is in the communication section. Okay, so it is very essential, and in fact, it is very neglected in our Indian scenario. We tend to develop a kind of what do you say, a paternalistic approach. So let us just, I think we'll be go. Have you all gone through the scenario? I think I shared in the this one. Can you see it, all of you? So I posted in the this. Yes. So who would be the? So we'll go in these lines.
Yeah, Dr. Surendra. Dr. Surendra Nad will be the like the examinee. Dr. Surendra, are you there?
Yes, sir. Yes, sir. I'm there,
Yeah.
sir.
So you can switch on your video.
Yes, I would suggest all of you to keep in the speaker mode as well, so that it will be a realistic experience.
Yes,
so
yes.
ideally,
we want to make it very realistic. Yeah, Dr. Surendra. Yeah,
Hi,
he's a
Dr.
very
Surendra.
intelligent and like a bright guy, and from Vizag. So he would be our examinee. Yeah.
Yeah. Thank you, Dr. Surendra, and I appreciate you taking the initiative. So always the guys who take the initiative, no, they'll to perform well in the exams. So this is a scenario you have gone through, no. So this is how we just briefly complete in the next 15 minutes. So I'll be the. I see you have gone through the scenario. Okay. So you will be the duty doctor there, or maybe a consultant. So you'll be coming and talking to the patient's wife, right? So basically the setting is very difficult setting. Young guy, unexpectedly he has sustained a very severe trauma in the motorbike accident, road traffic accident. Unfortunately, it happened in the middle of the night, brought to the ICU. The wife was not reachable. Some passers brought him to the ICU. Over the night, like as expected to the many medical professionals, he has deteriorated. By in the morning around 6 o'clock or 7 o'clock, no, the peoples were not reacting, and by all purposes, the brain is irreversibly damaged. Okay, so that is the scenario. And now I would act as a wife. Okay, so just imagine that I would come now and I would ask you, okay, your job, you should always understand your task. Okay, so there will be a task card given to you. If your task is to tell the wife that this patient has irreversible damage, maybe you're contemplating a next apnea test and brain death. No, you need to, your end of your discussion, whatever the 10 minutes or 15 minutes, your job is to achieve the task. Okay, and you need to close the loop. Okay, you understood it. No, you should not keep it open-ended, and the patient's attendant, or they should not go with a doubt in their mind. That should be the whole goal of communication, and you should do it in such a way that you have a compassion and empathy. Okay, right? Okay. So we'll be starting. Good morning, doctor. Myself, I am Mrs. Vasanti. I'm the wife of Mr. Vijay. I just came to know that you asked to talk to me. Please tell me, doctor, is my husband okay? I'm very anxious. I just came to know that he's in the hospital. I want to know if he's doing okay. Please tell me, doctor.
Okay. I am Dr. Surendra. He's a duty doctor on duty. I came. I received your husband in the night. We were unable to reach you in the night. So morning, we were able to reach you. Which language are you comfortable now? Which language are you comfortable now?
I'm okay with English, doctor.
Okay, fine. Actually, you know that your husband met with in a very bad accident.
And now I don't know about the badness and all of them, doctor, but I know that he is admitted in the ICU. Yes, I know that he had an accident in the night. Please tell me if he's okay, doctor. When can you discharge him?
Okay. Yes, sir.
Can he talk to me?
First, yes. First, I will make up a setting of a thing. I will make arrangement for the sitting and setup, sir. For the
Just enact the scenario. Don't worry about it.
Okay. Come, we'll sit there. Anyone is there with you, or you came alone?
I am alone, doctor. It's okay. Please
Okay.
tell me if I can see my husband and talk to him.
Yeah, definitely. But before that, I want to brief you about.
Thank you, doctor. When can I see him? Definitely, you said so. I think he should be improving. I think. Right. Thank you, doctor.
No, he's actually. I want to brief you about our husband condition now. Your husband met with a very bad accident yesterday night. He came to us emergency room in an unconscious condition. He is unable to respond, so we kept him on the ventilator
What is unconscious?
He is not responding to he is not responding to our when you are waking up him, he is not. So, and his breathing pattern is also not good, so he is not able to maintain the oxygenation level. So what we initially to secure his oxygenation level and airway, we put him on a that is a tube that to ventilate the lungs and to protect best further brain injury. He got a very bad brain injury.
Sorry, doctor. Apart from the badness of the accident and he is not talking to you, I cannot understand anything here, doctor. You said the oxygenation, you said ventilator, you said this endotracheal tube, airway. I'm sorry, doctor. Can I see him and talk to him? Just tell me that, and I think my kids are waiting at home. Can I please talk to him?
No, yeah, you can see him definitely, but he cannot be talking, no, because we put a tube in his breathing thing, that is a trachea, so he cannot talk. He cannot talk him. He is now not responding also. I can show. Sir?
Sorry if I'm asking any stupid questions, but what is trachea, doctor?
Okay. Actually, this is a thing that we'll take there are two breathe where we take the breathing.
Oh, that is the lungs. Thing that tube you are saying. Some tube was kept in his breathing pipe. Okay.
Yes.
Okay, doctor, not a problem. But I hope that tomorrow at least he'll talk to me.
No, he's not at all. He is not at all in a condition to talking now. First, I will show you the situation what he is in ICU. First, I will come and will show you, and after that, I will discuss.
Okay, doctor. Okay. So you showed.
So yes. Now this is the situation. This is what we do put in the lungs, and we are ventilating. What you are giving oxygen, and this is the ventilator. These are the things what these are the setups what you are doing. These are the monitors that you are connected. These are the parameters that is showing now, and he is not responding. These is the oxygen level, and these are the blood pressure level that we are showing in this monitor. This is the monitor what you do, and he is not responding. He's unconscious state. This is what he is not responding. So that you have seen your husband. Please come. I will explain in detail after you come, and you will have a sit in the out of the ICU where there is you can sit there, and we will discuss about your husband's condition.
Okay, but can I talk to him tomorrow at least?
No.
Is there any
now
when can he improve, doctor? When will be out of the ventilator, and can he talk to me?
Now I need to explain about your husband condition to you. He got
But
he
doctor, I keep on listening to this one. You kept on telling me that you need to explain, but we are already around 15 minutes into your counseling. Just want to know whether he'll talk to me tomorrow or day after. Just let me know that. I'm getting a bit frustrated with you, doctor. You
no
keep on
he
treating me like I
so,
don't know.
so, I'm sorry to say to you that he may not recover and he may not become normal as previous, and thus his brain is, we have a doubt about his brain function also, because we had done one
I have a
CT
doubt.
scan.
What do you mean by doubt, doctor? What do you mean by doubt? Sorry, are you not confident on yourself?
He came in the yesterday night in unconscious state. We kept him and we kept him this what is shown in the ventilator thing, and now he's not. He's what the cities we had done one CT scan brain at the night. It is not showing in a good. It is not showing in a good thing. They got a severe brain injury, and now he is not responding to he is not responding to our commands what you are shown in the bedside now. So what we can, you cannot explain at this point of time. He came in the within last 8 hours, 6 to 8 hours back only. So you can we can tell him about his brain function in the next 48 hours after. For that, we need to evaluate him, and we need to do some test about this brain function, and we will evaluate after. I will confirm about it, and we will tell about what is his condition in the next 48 hours.
Hello, doctor. I'm the patient's brother. So what is he talking? And I don't understand, doctor. You are telling something has happened, and you are like rolling and moving around the bush only. So you are not telling me what is happening. So, no, doctor. You are. I think you have kept the patient deliberately on the ventilator, and you are actually extracting money, and you are not doing proper justice to my patient. What is happening, doctor?
I had some sister also talking that he must have already died. What is happening, doctor? Are you doing this for money?
No. We are not doing this money. Just I need to explain to in a detail. I need to explain to in detail, and I will call my. I will first. I will call. I will explain in a better way. If you are not understanding, I will call my seniors or hospital authorities
You
to
should have
explain
done
in
it
detail.
in the first place itself. If you have a doubt in it, do we look like the kind of uneducated people to you? You should have called your senior first in the first place.
Doctor, I have serious doubt that you are qualified enough to treat my brother or not. So, doctor, you please involve your seniors. Where is the neurosurgeon? I cannot see the neurosurgeon in the ICU only, and you are the person who is taking care of like everything. And now you are telling that you don't know, you have no confidence on like what is happening to my patient.
Definitely, definitely your question is very reliable. We will set up a meeting with a neurosurgeon.
You mean to say you are not qualified and you are talking to us?
No, I am a qualified one. I have done my I am a qualified one. I am treating. I am the critical care doctor. We are qualified to treat the patient. And for to clarify your more doubts, I will call the other specialty people to discuss
Okay,
with
doctor,
you.
enough. Doctor, okay, enough of this, I think. Just let me know. I think you told me you are going to wait for 48 hours, right? So till 48 hours, what is your plan? And I think after 48 hours only, we are going to know about it.
I need to I need to explain you one thing about to declare to make a comment on his brain function. We need to wait for the next 48 hours to make whether his brain is functioning or not functioning.
Doctor,
Because
please tell me, you are again and again telling me 48 hours. If 49 hours something is happening and you are unable to tell me, can you take that guarantee that 49 hours you will be confident enough to tell me that everything will be okay or everything will not be okay? Are you God? Can you predict that 48 hours is the time frame? Is there anything written that 48 hours a traumatic brain injury patient, as you have discussed, my brother will be awake or my brother will not be awake? Is there any guarantee?
no, there is no guarantee at this point of time. The science is showing his brain is not functioning because he is not able to take his breath on, and the blood pressure also not maintaining properly. So what we have a doubt about his brain function, because there is a thing what you have read, and think we need to
I
wait
don't know,
to
doctor.
confirm.
You keep on using the brain
Doctor, you are
function.
not confident enough. I think we should quit the conversation now. You please call your seniors, your administrators, and what you are doing. I have to check the CCTV, what you have done whole night with my brother, and you have kept my brother dead only, and you are now trying to extract money from all of us. Thank you, doctor. We will see you
We
in
would
the
like
court.
to raise a police complaint on you, and I think we would like to raise a complaint for you in the hospital also. Whom do we need to talk to them in hospital if you want to raise the complaint on you?
There is a hospital committee, hospital ethical committee will be there. We will call them, and you can come. They will also come. We will set up a meeting with them along with me and neurosurgeon and other surgeons and physicians involved with this taking care of your brother or your husband, and we will definitely set a meeting with to make you all doubts clarify. Now now at the present of time, his condition definitely critical. His brain
Okay, doctor.
is
I'm okay.
Okay.
Being critical.
Thank you.
Okay.
Yeah, Dr. Swarnadeepak, you can. Thank you, Dr.
Yeah,
Surendra.
Sir,
Yeah.
That's Surendra. Great job. It takes guts to present, and it is that to take this one as well. And
Dr.
yeah.
Swarna, you
So-
can take over now. Yeah.
Yes,
You
yes,
could
yes.
summarize
Thank you.
everything. Yeah. Okay.
So,
Thank you.
yeah.
Thank you.
First thing is, it's
Dr.
pretty
Surendra, you can
difficult.
take a glass of water. Yeah.
and no sir, it's good.
Yeah. So I'll just summarize. Okay, I'll be an examiner now for you. Okay. So what are two of the things I'll tell you, right? So it's definitely a very difficult scenario. So breaking the bad news itself is very difficult. Okay. And apart from it, I think breaking a sudden bad news, like bad news itself, doesn't mean that it's only a cancer declaration or end of life. It doesn't mean like that. Anything, any sudden change in the patient status of the families, no. So closed ones, any loved ones, anything is a bad news. Okay. For the wife, if you see from the wife's side, she just wakes up from her sleep and comes to know that the patient is in the hospital, husband is in the hospital. So it's a very traumatic thing. Okay. First thing the one I really appreciate is you never lost your composure. Okay. You were calm throughout. Okay. That was one good thing. Okay. Another one thing I would appreciate you is you asked if you see. First thing, as you rightly said, no, setting is the most important thing. Okay. All of you know about the spikes protocol, right? Every one of you should learn about it, and you should always try it. Okay. If you practice the spikes protocol, which is basically breaking the bad news. Okay. It will be very easy both for your exam and in fact in the practical also it will be very easy for you. So one good thing you've done. Okay. How do you think you have performed if it is a real exam scenario from your side? Any mistakes you thought you can correct it?
Yes sir, actually little bit in communication in a proper way, and I could have tell them prayer to show them first. I could have showed them the patient first, and I should have shown the scenario of the patient. Next I could have make her come and sit a position on a place, and I could have discussed with her. That I didn't done that first.
Okay. So, one other thing is you used too much of medical jargon. Okay. So you used a lot of medical words. You are aware of it, right? Right from
Yes.
the endotracheal tube, ventilators, and oxygenation, everything. Right. And like all of us, basically we converse in the medical jargon, so it's very difficult. You need to basically again go back to the layman terms. Okay. For a layman, you need to use breathing pipe, kind of all those things you need to use. Okay. First thing, another thing you've done is there's no gaps between each communication. Okay. There is something called as non-verbal skills. Okay. So your non-verbal skills plays almost 80% of the role in communication. Only 20% will be through the verbal communication. Okay. So the way you're sitting, okay, there is something called as solar. Okay, sitting the straight. It's a open stance, right? And leaning towards the patient. You can always lean towards the patient or patient attendant. Okay. Show the empathy. There's a respectable silence in between. Okay. All these things are really important. So one thing, if you want to again reenact, no, you should use gaps between it. When you declare something or when you use something bad, no, there are something like I wish, okay, I'm very sorry to say this. There are some stock kind of statements. So you should always make sure that you use them, okay. Either it's an European exam or for your DNB. Most of our now DNB exams are basically styled upon your MRCP exams, okay. Yeah, communication section. You should always use it. I'll tell you, okay. I'll just make a 5 minutes of presentation and I'll tell you the exact one, okay. Second thing I identified is you should have asked her, you should have given her some cue in the starting itself, right? Initially, you asked her, "Are you comfortable to talk now?" Okay. Before that, you told that you introduced. Okay. So the one good thing was I introduced myself that I am so and so. I am Mrs. Vasanta and wife of Mr. Vijay. Okay. If that was not there, no, then you should ask, "Ma'am, are you the wife of Mr. So and so?" So you should always identify. Many other times, the consultant, the communication, entire thing will be gone lost because some other person's attendant will be coming. No, it will be catastrophe. You declare some bad news to a stable patient. So you identify yourself, you identify and ask for the identification of the family also. Before that, the setting. Okay, in a real exam scenario, you need to make sure that you're in a private room without any interruptions, right? You should switch off your phones, maybe keep it in a vibration mode, okay? Or keep a glass of water. Especially your whole point is anticipating the a bad scenario. You should keep a glass of water, maybe a box of tissue. Make sure that the environment is light. All those things you should be doing in the setting. Okay. After that, you identified. Then one another correction you could have done is you should ask for the patient perception. You asked it, but maybe you could have maybe better compassion you could have showed. What I'm saying is you should give them a lead that you're going to declare a bad news here. Okay. Ma'am, I'm sorry to say that this bad thing has happened, bad accident has happened, he's in a serious condition. So somehow you need to give them the cue there, right? And subsequently, you need to again ask them, are you prepared? I have something actually unfortunate thing or bad thing to tell you. Are you prepared to listen, or you want your mother or maybe your brother to be there with you to listen to it completely? Okay. If at that point of time, if they tell you, I just want to take a break and bring someone, you should give them some gap and you should ask the other person also to come. Understand? So that is called as invitation in the spikes. Then you should ask them, completely tell me what do you know about them. Then you should again share the knowledge. The knowledge should always be given in the small pieces, small chunks. Okay. And you should always keep a respectable distance and silence between each chunks. Here, how do you tell it? You're going to tell that, ma'am, yesterday we received your husband. He was to come with, he was in a very bad state and he was not responding to start with. Okay. So I understand that this is a very bad accident at this point of time and he was on very high supports. Then you give a gap. Give some gap to express themselves at that point. Okay. The expression can be maybe a crying or maybe an anger, whatever it may be. Okay. So subsequently, then you need to again tell them that he has deteriorated. Okay. So there, these local terms are very important. Local languages are very important. But for your exam, English is the one where we communicate. Then you should close the one thing I actually wanted to correct you is you never closed the discussion. You always kept it open. You are saying that even at the end of the discussion, you are saying that the patient was critical, but you are here contemplating brain death. That means already the irreversible damage is over. It's only a matter of testing it and confirming it. Okay. Right? So you should make that point very clear. You should not here as you have done, no, you should not give a hope that after 48 hours there may be some hope. It's still critical. They should not go out of the room with that hope. That is your task, isn't it? Your task is to make sure that close this discussion and they should go with the opinion that it is a hopeless condition, right? Then ultimately you should again you should again ask them. Here the scenario basically went into a different tangent, like angry patient, angry attendant. That is a difficult scenario to handle with. One good thing is you maintained your silence altogether. Okay, right? And here they wanted to sue you. Okay, they questioned your qualification, questioned your like the way you treated the patient, and they again questioned, are you treating a dead body? He must have passed already. All those things they raise, these are all difficult scenarios. The way you should handle is you should be firm in your this one. Okay, you should always tell that I'm a very qualified person. In fact, we are a part of the team. Always the team concept should be there. It's not an individual concept. You are a part of the whole critical care team, and whatever the overall neurological team. Here, Dr. Tapas asked you, I don't want to see the neurosurgeon, I want to see this one. No. So you're all part of the same team. You should be very firm and tell them that we're all part of the team and I'm representing my team. You can always talk to them. If you are free to do that one, I'm very sorry to tell you, this is an unfortunate news, but we stand by our whatever the condition which we are saying. You can always get the help of the social worker. You can guide to them and tell them, right? And lastly, they are asking you, I want to show you, okay, I want how to show you in the hospital. Whom do you need to complain? So each country, there are different terms, okay? There is something called as grievance committee, hospital, legal cell committee, lot of other terms are there. Grievance committee is a general term, right? Legal cell is a different one. And the dictum states that you should never guide the attendants towards the legal cell. Okay, you should not deny that if they are questioning you, they want to really show you. You should not basically stop them, but you should not utter yourself that you can go and show me. I'm okay with it. You should not lead yourself and the hospital into the legal suit. Okay, but you can guide the. You can give them the number. That's the reason. Always behind you there should be a social. I'll always. If your system is a JC accredited system, you should have a social worker in place. Okay, they are more laymen and they'll be connecting to the people. Okay, so you understood what are the mistakes and what we could have done. I'll just show you one small presentation. Okay, 3 minutes we will complete it. Okay, this is the scenario we have started, right? Can you see this? Okay, so bad news is basically it's not about the death or it's not about the cancer. Anything which suddenly changes the world of the patient can be bad news, right? These are the components of it. You should always set the interview, the room you're offering. In your exam scenario, this may not be ideal, but you should always offer this. Okay. Preparation, basically preparation and anticipation, and you should make a task points on your paper before going into the communication room. Your task is to declare that the patient has an irreversible brain damage and you are basically contemplating a brain death testing, isn't it? For that one, you need to anticipate the difficult scenario, and always you should have in your mind that this is a very difficult scenario of the bed because the attendant doesn't have a previous idea. If she was there throughout the patient over the night in the outside the ICU, this would be a difficult, easy scenario. Even though it's a difficult one, among them it is a relatively easy one. Now it is a difficult one, isn't it? So here, 2 or 3 things in a Zoom it will be difficult, but in a real scenario, they'll always the examiner will observe you how your what is your stance, what is your eye connection, are you making an eye contact, and all those things. Perception also, as you told, these are the open-ended questions. So what do you think? What it is? Whether do you think it is a serious condition? Here it is too difficult. You need to improvise it, but it is more of a stable condition. You can all do these things. Okay. Invitation, as you told you can always ask if other attendants also can be part of it, and you're going to deliver a bad news, isn't it? So knowledge, as I think one of them rightly pointed out, no. So you should always give in the small chunks, small bits, but at the same time, each of the chunks should have enough seriousness, and there should be a silence between both of them. Silence plays a huge role in communication, and the examiner actually very closely. In fact, I'm an MRCP examiner also. I've seen people failing the student just because they are not maintaining proper silence between the each delivery of the information. Okay. And you should always avoid excessive bluntness. Okay. If there's no need of it, avoid the bluntness. And the end of the day, you can always offer, see, even here, you can always offering an organ donation. All those things are too radical here because it is a very sudden news and all. But the offering you can do is you have a social worker at hand, you have a religious person, maybe a priest or someone who can offer a solace to you. Okay, all those things you can offer to them, and you can always tell them that even though your like husband is in this condition, we are trying to see that he doesn't suffer through any pain. Those are basically about your comfort. Okay. So these are the empathetic response. Okay, you need to first identify the emotion. If they're are they crying, are they anger? You need to first. Some people basically don't even observe the other attendant, other family member. They keep on talking and they'll just want to finish off the station. You should not do it. Okay, you observe it and then you identify what is the this one. You empathize with the attendant. Then you're going to connect with them. So these are the basic statements. You can use it. I'm sorry. Okay, it is very difficult for me also to tell you this one, these things, no, and I think someone has pointed that I wish. All these things are very useful. Okay, so this is what I was telling you. Always sit squarely, adopt an open body posture, lean towards the patient, maintain an eye contact, and make sure that you have a relaxed, don't be very stiff. Okay, and these are the verbal responses. Okay, when you're basically talking, you can do that, but more importantly, examiners will be more observing you the non-verbal cues. They'll definitely understand. Okay, so ultimately, strategy in summary, here there's not much of it. Ultimately, if they haven't reacted in such a way in the last one, you should then you should actually tell them, ma'am, we're going to test this one, and I don't know why you uttered the 48 hours interval. Ultimately, you are already about to do the apnea test at this point. No, another 6 hours you're going to declare the brain death also. So there's no reason to wait for 48 hours. You should tell them this is the way we are going ahead, and maybe then this is the, and here is the time you can always include the organ coordination and are not in a very obvious way, but you can involve them along with the social worker and get the perception of the family. Okay, ultimately, once you do this one, don't get upset by it and check your own feelings as well, because you have too many bad news to break in your ICU. Okay, so that finishes my one. Any questions you can always ask.
Sir, can we declare the brain death within a span of 6 to 8 hours, sir?
After the second apnea, you can declare, right?
Actually, we need to wait for
Yes.
48
your,
hours.
your question, yes, no. Your question is basically, can we do the brain death testing immediately or not? Isn't it? So usually, at least after the admission, you need to, basic thing is you need to wait for 6 hours to basically think about the brain death testing and all. Okay. So, but here, for whatever the reason, basically it is very obvious. Okay. And you're going to, the consultant has already decided that they are about to do the apnea test. And I don't think there's any reason to wait for 48 hours. Tapas by Samantha, allow anything you can.
It's a different practice elsewhere, Deepak, but in Australia, we usually wait for 48 hours, but that's not the motto of this session. So I think the communication
Scenario is basically to test your communication skills. Yeah.
So I think the scenario was very, very exam oriented, and you did a very fantastic job. So my approach, I'll say, it is a very easy approach for communication. I tell my trainees always. So don't go about the aim. So your question was about, we are going to do the brain death test, but in the examination, they usually see how you approach. Don't bother about whether you have told the brain death test that I'm going to do. The points that Deepak mentioned, like empathy, setting up, and all those things are important. That's what the examiner look at. They don't look at the end result up to what communication you were able to go, because the communication station is 10 minutes and you may take an hour to talk to a family. So they don't bother about the end result of the communication. They see the process in the exam. Just remember that. So somebody says, oh, you need to tell the relative that they have to pay the money which is standing there to the hospital. They have to pay, and then only the body will be discharged. Yes, that's in the question, but they don't expect you to have that result in the communication. They look at how the process that you have adopted or not, and how smoothly you have gone. So that's the first thing. Second thing, to make the communication easy, make sure that what are you going to talk, right? So in this case, Deepak has put that the brain death test means the patient is in a bad state. So the first thing after introduction, offering her a seat and asking for any family to be present, just utter your aim in a very polite way. I have something bad to tell you. So that's the thing which catches. If you start, oh, he came unconscious 6 hours ago, then we put a tube in. These are all unnecessary things the relative doesn't want to listen. They want to listen how the patient is. So if you start by saying that I have some bad news to give you, then they automatically go into that plane where they will ask, oh, what is the bad news? They're more concerned about that now. So make sure that your aim is conveyed to them at the beginning in a empathetic way, not like very rudely, oh, there is something bad is happening, I'm going to tell you. Not like that. I'm sorry, I have some bad news to deliver. So that's the way you start so that forthcoming things become easy. There's no bush, beating around the bush after that. So I think that's the main point that I want you guys to catch. If you are given something in the exam that you have to deliver a bad news, suppose a registrar did a pneumothorax and you are going to counsel the family. So after introduction and everything, offering them seats and everything, the usual stuff, tell them why you are there in a polite way. So that, sorry, there is a complication that has happened to your patient. I want to talk about it. Just to the point. Don't tell that, oh, he came, we intubated, he is on 100% oxygen, on NORAD. So these are all things the relative doesn't want to listen. Your aim is to tell what has happened to the patient. Go straight there with a bit of empathy in it. I'm sorry, there is a complication that has happened to your patient or to our patient. I want to talk about it to you. So that's the bottom line that sets the tone, right? You understand, straight to the point rather than, because you will have 10-15 minutes for the communication station and you have to utilize it the best way. And once you put forward the aim of the meeting, everything gets better after that. So when you analyze your conversation, you were trying to go to the apnea test repeatedly, but the relative was saying that, oh, is he okay? He is going to wake up tomorrow. Can I talk to him tomorrow? This is because you did not start in the beginning saying that I have some bad news to offer to you, or I have some bad news to declare. Do you want anyone else around you to listen to me? So if you put that important thing, they will not talk about anything else. Got that? I think that's the main message in communication station. Yeah.
Yes.
Yeah, Dr. Sanant and Dr. Deepak, you have explained well. Two things I want to highlight here. For the exam point of view, look, breaking bad news is an art, and it has to be inculcated in a gradual way in your training period. For the exam purpose, if I will start teaching, or Dr. Deepak would be start teaching like all the points and how you would be addressing in the exam, it would be difficult. You will be totally confused. So in the exam, if I would be focusing on the exam, and this is a debrief test for your exam, so the examiner wants you to apply the principles of communication in each the question. So they would try to extract from you whether you know the solar principle, whether you know the spike protocol, whether you are involving the multidisciplinary team approach, whether you are empathetic to the patient, whether you are addressing with the evidence rather than only talking about emotionally and trying to pacify, offering a glass of water, other things. But you are not talking about a traumatic brain injury with intraparenchymal hemorrhage, with herniation, whatever, as per your clinical decision, that what is the current evidence of this type of injury. So the examiner would try to know in a systematic manner. So all the delegates here, they are attending. Breaking bad news, as Dr. Deepak told, it's an art. It has to be learned in a in your training period and over a 1 to 2 year. It cannot be taught in a half an hour class. So it is not so easy. It may be scientific way to discuss about hemodynamic monitoring or ventilatory parameters, or managing rescue strategy ventilation, but communication is really difficult. It is has to be learned in a very systematic manner. But for the exam point of view, Dr. Surendra, you have to use all those principles of the important communication skills. The examiner wants to know that you grasp over those communication skills. I think I am making it clear with all the delegates, because all those aggressions, all those things, that is okay with the familiarity, but in the exam it will be only for 5 to 10 minutes, and they would try to extract at least 5 to 7 principles of communication or breaking bad news from you, and the marks will be allocated on that basis only. Am I right, Dr. Deepak? How it happens in MRCP?
The same way, I think they basically there are divisions in it. They'll basically see is the candidate is a safe person and is he giving importance to the patient safety and concern. That is the more important one, and is he showing the empathy? Okay, and is he basically at the end of the discussion, are you actually giving a correct idea that, for example, your task is to tell the attendant that it is an irreversible damage, but you are giving a wrong idea that there's still hope at the end of the discussion, you're going to obviously fail. Okay. The minor things, the angry attendants, they'll be coming and they'll showing you,
That's
please,
okay.
they're okay. And they'll be seeing you. Obviously, it is difficult even in real practice as well. That should not be done, but you should not go in a tangent from your task given, and you should not basically see very fastly. You should not be too rude. You should not be too blunt. And medical jargon, they're very important. You should never use medical jargon. It is very difficult for us to not to use medical jargon, each one of us. But you need to actually learn how to not to use it. Okay, and right from now, you need to practice on your real attendance and see not to use the oxygenations, peeps, ventilators. You should not do that.
Yeah. Thank you. It's a 3-hour extensive discussion, and at the end, Dr. Surendra suffered a blow when I entered into the picture, and I became aggressive.
Don't worry.
I learned,
I
sir.
got the
Learned so.
message. I would be clear, little bit true. Dr. Sanand has sent me personal message that let's take it easily. Dr. Surendra could have taken it.
No, sir. I understand the situation. How to?
So
This is
this is a learning platform,
Yes,
and
yes.
make sure, and it is sure that
You're
nobody is
done well
judging.
for the first time.
Yeah, nobody is judging anyone. It was really a great effort from you that you stepped in, and this will help you in the exam for sure. Definitely, it will help.
Yes.
And,
In
and,
front
and
of all this,
practice. Yeah.
yes.
And
65,
practice
70
it.
candidates. I would congratulate Dr. Surendra for voluntarily accepting the invitation to be part of our this examination process. Until the last minute also, he was talking that I would be talking to you. let's go for the discussion.
I think we can keep him as our course communication master for the next year. Okay. Anyway.
Okay.
Thank you
very
Surendra,
much,
for
sir.
your effort. Thank you.
Thank you, Dr. Surendra,
Thank
and
you.
thank you all
Thank
the
you.
faculties, Dr. K. Surnadepak, for excluding the aggression part. He has explained everything so perfectly, and Dr. Santanu, Dr. Biswavikas, Dr. Mona Lisa, and Dr. Sanant for sharing their the experience as well as expertise for the trainees. And at the last, we must thank all the delegates. After 3 hours also, there are 40 candidates still logged in. From 85 candidates, we have reached to the maximum. And definitely, it's a learning experience for everybody. So please share your feedback. And if you have any queries, please post in our WhatsApp groups. Definitely, we could not answer all the questions in this 3 hours limited time, but definitely we would clear all those doubts in next 1 month before your final exam. Thank you, all of you. Best wishes, and we wish that all the delegates who have joined in our course as well as our debriefing session, they would come with flying colors. And this is just the beginning. We'll be learning a lot from you also in our upcoming courses. Maybe some of you will be the faculties in our upcoming courses. Thank you. This is our last class, official class from the top course. For last 4 months, we have really worked hard. Apart from our own assignments, clinical like job profile and other courses, we tried our best to provide you the up-to-date information as well as the guidance. So if you have any doubts and queries, please share so that we will improve in our upcoming courses. Thank you all. Dr. Sanant, could you please share few tips to the candidates?
I'll say thank you to all the candidates and more so to the faculties. Like, they have worked endlessly, especially Surnadepak, Shantanu, Mona Lisa, Bisu, and another 10 or 15 people. So their effort will surely count, and it's really appreciated. I'll wish best of luck to all the candidates. And I will request one thing, just go through the videos of at least the mock exam videos and the vivas that we did, around 10, 12 videos that is there in the YouTube before the exam. Make sure you repeat it. So I can guarantee you can get up to 20-30% of questions from there. So it is a low investment, high profit thing, I guess. So definitely go for those videos. I think it will be worth 10 hours of video, but it can cover at least a pass mark. So it's worth watching. They're all free if you are not in the sense free, but if you are in the course, then they are definitely you can access. And there are few free videos also in the website, in the YouTube, so you can access them. They will be high yield for you guys. Thank you and best of luck again.
Dr. Vishwavikas, Dr. Santanu, before we log out, Dr. Mona Lisa, anything, please share. You are all the stalwarts in our course who have dedicated so much of their precious time for these classes and these mock tests. If you want to share anything, please feel free.
Nothing much, thanks everyone. But the one good thing I noticed is that in the chat box there were multiple suggestions from the fellow examinees also regarding how to correct the answer approach and all. What should be the modifications? That was very nice to see. And definitely this approach should be there. And all the best wishes for all of you. You all will come out with flying colors. I strongly believe with the visionaries we all have. Thank you. Good night.
Thank you, all of you. Good night.
Thanks,
Good night.
Tapas. Thank you. Bye-bye.
All the best.